Oh yeah, we did. Okay, let
I
me
received it. It's on my
I
desktop,
just met.
but
Yeah,
I
yeah,
don't
yeah.
know
We
how
just
to
received. Yeah, yeah. I'll just change it. Yeah.
choose virtual background. Then how do I?
After a minute, you will have to.
Yeah, ma'am. Where do I find it? Video filters. Okay, I need to add it. Yeah, add image. Virtual background. Yeah. Got it. Perfect. Yeah. Okay, I'll stop sharing now.
Yeah.
We are live.
We are alive.
Sorry. Stop share.
Should I start?
Okay.
We are live now.
Okay. Very good evening to one and all of you for an absolutely wonderful webinar, because we have the top experts in the field of cataract surgery amidst us, and we have the very best of speakers. And we have great discussion plans with all of you. I'm sure the next 2.5 hours would just fly with so much of knowledge gained for each one of us. I'm truly happy to have with us Dr. Ramurthy, who's going to join us soon, who's the chairman of the Eye Foundation Group of Hospitals and the past president of AIOS. We have with us Dr. Mahipal Sachdev, who's the chairman and the medical director of the Center for Sight Group of Eye Hospitals. Again, a past president and Padma Shri. We have joining us soon Dr. Jeevan Titiyal, who heads the RP Center and is also the specialist in cataract, cornea, and refractive services, versatile surgeon, like all of the above. We have with us Dr. Mohan Rajan, who's joined us, who's the chairman and the medical director of the Rajan Eye Care Hospital, Chennai. Another very prolific, versatile surgeon, and he is going to have us learning a lot more over the course of 2.5 hours. Joining us soon is Dr. Partha Vishwas, who's the director of the Trinetralaya and also our very popular chairman scientific committee of AIOS. And joining us soon is Dr. Krishna Prasad, who's a senior consultant, glaucoma squint oculoplasty services, and also one of the senior directors of Joshi Group of Eye Hospitals. Moderating with me is our very dear Satyajit Sinha, who is the member ARC East, who's the chairman and the medical director of the ABI Institute based at Patna. Amazing friend for one and all of us. Each of us would claim that he's their best friend, and is a national figure in the field of ophthalmology of our country. And I'm truly enlightened to have you moderating with me, Satyajit. We shall go on to our speakers. And the first speaker to start batting is Dr. Tamil Arsi, who's a senior consultant, cataract and IOL services of the Eye Foundation Group of Hospitals based at Coimbatore. She is an amazing surgical trainer for all the postgraduates and the fellows who are at our hospital. And for me, she's the most valuable friend of a lifetime. She is going to be talking to us on Phaco dynamics and overview of Phaco machine, all the essential points, and stick to your 8 minutes, Tamil.
Good evening all. Thank you for your kind words, ma'am. Phaco dynamics is understanding the nuances in the dynamic changes of fluidics and the ultrasound power delivered in the eye. It is important to realize that there are no universally accepted settings. Every eye and every surgery is different. What we should know is why we'd want to change the fluidic and ultrasound setting for different situations. Before we start using any Phaco machine, it is imperative to become well versed in its features. All Phaco platforms share the same basic structure and concept. Each machine has its own fluidics for inflow and the pump which governs the outflow. It has the chamber stability software for surge control, which ensures that the inflow is always more than the outflow. The Phaco handpiece and the tip design, what we use should be compatible with that machine. Understanding this technology has become as important as understanding the surgery itself. We control the two important components of Phaco dynamics, that is the fluidic circuit and the ultrasound energy, by these 4 parameters, which is the bottle height or the target IOP, the aspiration flow rate, vacuum, and the ultrasound power. The first is the fluidics. The fluidic stability is determined by the infusion pressure and how well we can maintain that at a constant level. with a gravity-fed fluidic system, we can raise the infusion pressure by raising the bottle height, but in doing so, we are also creating a higher gradient for surge. Air pump is used to achieve high infusion pressure, as in Stellaris Vision Enhancement System and Veritas Vision System. Active fluidics works by maintaining the target IOP set by the surgeons. All these increase the safety and the efficiency of the surgery. What happens in gravity-fed fluidics is that the bottle height is constant, so the static infusion pressure, but the IOP fluctuates. In order to work at an IOP of 55, we have to face IOP as high as 80 during occlusion and to the minimum when the occlusion breaks. What happens in active fluidics is there is a variable infusion pressure in response to the pressure sensors which are there in the irrigation line, aspiration line, and within the handpiece itself, in the active centric handpiece, which helps to maintain the surgeon set target IOP. Where we vary the inflow, especially we decrease the bottle height when we are operating in a high myope or post-vitrectomized eye. Here the bottle height is lowered, and in order to prevent the reverse pupillary block, enter the visco-filled eye in foot pedal position 0 and then lift the iris and then step on to foot pedal position 1. This ensures that the fluid goes both to the posterior and the anterior chamber and prevents reverse pupillary block. We control the outflow using these two parameters, which is the aspiration flow rate and the vacuum. Aspiration flow rate determines the pump speed, that is the speed of the procedure. It also determines the distal followability, that is how well the pieces are attracted to the centrally held phaco tip. If things are happening too quickly, then we have to decrease the flow rate and vice versa. The vacuum is the negative pressure in the aspiration line, and in a peristaltic machine, it reaches the maximum only on complete occlusion. Clinically, it translates to holdability, and hence we should operate with high vacuum for chopping. The third component is the ultrasound modality, and we have this torsional and elliptical ultrasound modality to increase the efficiency, reduce the amount of phaco energy used, and to decrease the chatter as against the traditional longitudinal ultrasound. Additionally, we have the pulse and burst mode to decrease the amount of phaco energy used, which we can decrease by varying the duty cycle. And what is this duty cycle? Is phaco on by on plus off time. To the left, we have a duty cycle less, which we use during chop, and a high duty cycle as seen in right, we can use during sculpting and quadrant emulsification, especially in hard cataracts. The goal of modern cataract surgery is ultrasound assisted aspiration of the lens. A heavy foot in position 3 wastes energy and also invites complication. So by adjusting the percentage of travel devoted in 1, 2, 3, we can master this. So spending most of, that is 40 to 50% of the excursion in foot pedal position 2 gives us two advantages. One, it gives the best energy to fluidics ratio during quadrant emulsification. And second, it expands the travel in position 2 so that it reduces the chance of entering the position 1 during chop, and hence we can perform the chop efficiently. The next, when we are switching to different machines, we have to make sure that the keratome, phaco tip and the sleeve matches. We all aware of this thing that inflow of the balanced salt solution will cool the phaco tip, and additionally any egress of fluid outside the incision will add an additional thermal benefit. Here the wound is too tight and there is a kinking of silicone sleeve, so it fails to cool the phaco tip, which results in burn, which we can see as whitening, which happens during sculpting. Another cause for wound burn is doing phaco emulsification in a viscoelastic overfill anterior chamber, especially with some viscoelastic like a combination of sodium hyaluronate and chondroitin sulfate, which can block the fluid flow and lead to phaco wound burn. Another important variable in fluidics is the phaco needle size. According to Poiseuille's equation, the outflow is related to the radius of the tip to the fourth power of the cube. So when there is a small change in the phaco tip size, the flow rate is affected significantly. So in order to bring the same flow rate, we have to work by increasing this pressure gradient, that is by increasing the vacuum. The final point is we have to optimize the setting according to the surgeon's technique and experience. Here is a case of a Brunerson cataract when I'm performing stop and chop. Here the phaco power, what is used is continuous with this white star technology on, which has a micro on and off period. This significantly reduces the amount of phaco energy in the eye. It is preferable to use the power always in a linear mode. We can have a non-zero start. The aspiration flow and the vacuum is kept low in a panel mode. If the nucleus is moving when we are sculpting, it means the power is inadequate and we have to increase the power. Chop is everything about holdability. So make sure that the phaco tip is adequately exposed and impale in the middle third of the nucleus. And here the vacuum what is used is 430 and the aspiration flow rate is 35. This 35 decides how fast we are reaching this maximum preset vacuum on complete occlusion, that is a rise time. And here the one nucleus can be chopped to 3 to 4 since it is a hard cataract. The quadrant emulsification is we have to concentrate on followability and the chamber stability. The power what I'm using in this quadrant emulsification is continuous. And for dense segment, the duty cycle is 8/4, which translates to 66%. And the vacuum of 500 and aspiration flow rate 42, both in a panel mode. The vacuum can be kept in linear mode when you're operating near the capillary structures, especially in epinucleus removal and cortex removal. The peristaltic machine, what we are using now with a good surge control software, allow us to operate at a higher flow rate and vacuum safely and trying to mimic the efficiency of the Venturi platform. Surge can be experienced as minimal fluctuation in the anterior chamber depth. And whenever a surgeon is experiencing surge, it's first to check the inflow, that is the bottle height and the tubing. And second, the outflow. Look for any wound leak or any undue pressure on the incision or the side port. And if everything is normal, then we have to decrease the aspiration flow rate and vacuum by 10% and then look for surge. Here, I failed to notice that there is a mismatch between the keratome, which was 2.8, and the phaco tip, which I'm using is 2.2 with a 2.2 sleeve. So changing to a 2.8 phaco tip and sleeve resolves surge. So by using appropriate phaco energy, perfecting the fluidics to reduce the turbulence inside the anterior chamber, and appropriate use of OVDs will help us to achieve clear cornea in the post-op day 1. Thank you for your listening.
Thanks, Tamil. That was a wonderful talk. You just covered everything which we needed to hear. I think we would take Dr. Sheetal Prar's talk and then go on to discussing both the concepts. Now, Dr. Sheetal Prar is our senior consultant of Phaco Refractive and Cornea Services at the Netradama Super Specialty High Hospital. And I think she is one and only person who has the most numbers of coveted awards. And we are truly happy to have you amongst us. And she is going to be talking to us on principles of femtosecond laser systems and overview of the different platforms.
Thank you so much, ma'am. Thanks for the opportunity and for the kind words. So good evening, friends. Today I'm here to discuss with you all some principles of femtolaser systems for cataract surgery and overview of different platforms which are available today. So I think there's enough evidence available now to say that femtolaser surgery or the Flacs has certain advantages over traditional phaco surgery, such as it provides us with precise corneal incisions, precise capsulotomies, nuclear fragmentation, and this is very important for endothelial health in the long term. And also it helps us in certain difficult and challenging cases, such as Intumescent cataracts and subluxated cataracts as well. So getting into the basics of this, so femtolasers for cataract surgery are basically solid state lasers that emit ultra short pulses of near infrared wavelength. So somewhere here in the electromagnetic range of the light. So this the duration of these pulses is in the domain of femtoseconds. So when we say femtosecond, it means 10⁻⁻15 seconds. And in 2009, Nagy and colleagues, they proposed a novel idea of using these ultra short near infrared wavelength pulses for cataract surgery, for performing certain key steps of cataract surgery. And this was later known to be known as Flacs or femtolaser cataract surgery and was FDA approved in 2010. Now, principally, the femtolasers are similar to YAG lasers. You can see that the wavelength is quite close. They're quite similar. They work on the same principle of photodisruption. However, the main difference is in terms of the pulse duration. So with YAG lasers, the pulse duration is in nanoseconds, which is 10⁻⁹. And for femtoseconds, as I said, 10⁻⁻15. So the pulse duration is much shorter with femtoseconds, which has a big advantage in terms of the collateral damage that it creates in the tissue. So with femtolasers, the collateral damage is within 1 micron, which is very important for high precision corneal as well as cataract surgeries, whereas it is much higher. The area of collateral damage is higher almost up to about 100 microns with the YAG lasers. So these lasers can be focused anywhere within or behind the cornea and are capable to a certain extent of passing through optically hazier media as well. Now, looking at the principle of photodisruption or laser-induced optical breakdown. So when a pulse of laser energy is focused to a precise location anywhere within the cornea or any other tissue, say even the cataract, so it creates a microplasma, which is nothing but an expanding bubble of ionized tissue. So this microplasma then increases in size, it expands further and starts to separate the tissue. Now, thousands of such laser pulses are then connected together in either a raster or a spiral pattern to define a resection plane. And as a byproduct, gas and water is produced, which is absorbed by the endothelial pump or whenever you lift the flap or open up the incision. So we have different commercially available systems available in the market as of now. 5 systems are available: Lensex system from Alcon, Catalyst from J&J, Victus from Bausch & Lomb, Lenzar from Lenzar, and Femto LDV from Zimmer. So these systems essentially differ from each other in terms of pulse frequency, pulse energy, pulse duration, spot and line separation, as well as the docking systems. But however, all of them have certain common features. So all of them are integrated with a real-time OCT, which provides us with 3D visualization of entire anterior segment during docking, planning, and throughout the procedure. This is also required to verify patient's position and reducing tilt during the docking. And they all provide us with customized incisions, capsulotomies, and various types of nuclear fragmentation patterns. Now, individually, if you see in terms of the pulse frequency, the Femto LDV has the highest pulse frequency or the pulse repetition rate, which is 2 megahertz, compared to the other laser where this ranges between 80 to 160 kilohertz. So it's much faster laser. And in terms of the pulse energy, also this laser has the least energy in the range of nanojoules, less than 50 nanojoules, compared to the other lasers where it's within the range of 15 to 30 microjoules, which is comparatively higher. In terms of the IOP rise during suction with Lenzar, LDV, and Catalyst, it is more within the physiological range of 25 to 30 millimeters of mercury because they use liquid immersion interface, whereas with the other 2 lasers, it can be as high as 65 to 42 millimeters of mercury. You can set the safety margin from posterior capsule, and the range could be anywhere from 0.4 millimeters to 1.5 millimeters. And you can also set the capsulotomy incision depth from 0.4 to 1 millimeter, depending upon the type of cataract that you are operating. So I said about docking. Docking is a procedure which is required to enable the transmission of the laser from the laser to the eye. And this is done through using a patient interface or PI. Now the PI can be of 2 types essentially. The first one is a curved contact interface and the second one is the liquid interface. So when it's a curved contact interface, basically the interface touches the cornea, which can lead to posterior corneal folds, sometimes difficulty in visualization, and also rarely incomplete capsulotomies as well, and also higher IOP rise compared to liquid PIs, wherein this eliminates corneal folds because there is no touch to the cornea as such, and a reduced incidence of subconjunctival hemorrhage and lower IOP rise. So Alcon was the first femto laser cleared by FDA. The PI of this machine is called the soft fit PI, wherein a soft contact lens technology enables the natural curvature of the cornea to conform to a soft contact lens and minimize corneal distortion. So this was shown to reduce the IOP rise by about 20%. With Catalyst, you can see the docking system is the liquid optics that includes 2 parts, a suction ring which is fitted onto the eye of the patient, and then this is coupled to a cone which is attached to the console of the Catalyst optic system. Here you can see actually the patient's bed has to be moved and the eye has to be taken towards the laser. And the IOP rise, basically you need about 15 millimeters of mercury to achieve an adequate vacuum with this machine. With the Victus Bausch & Lomb, it has 2 components for laser docking, a low pressure suction ring and a curved interface cone, which is controlled by 3D pressure sensors. So this machine has pressure sensors which sense the change in the pressure levels exerted on the eye depending upon the treatment. And it also has another special feature that you can change the frequency of the laser from 80 kilohertz for flacs, that is cataract surgery, to 160 kilohertz for a flap procedure. So it can be used for both cataract as well as refractive procedures. The LENSAR system is the one we are currently using, and it has certain special features. First one, which is not available with any of the current lasers, I think, is the wireless integration of the laser with certain Scheimpflug devices such as Pentacam, Cassini, and Sirius. So this is a big advantage, especially when you're planning toric IOLs as well as planning your AIs or arcuate incisions. So you can see in this particular patient, there was a cyclotorsion of 15 degrees, and this was automatically compensated by the laser. And this is because the Pentacam, on one day before the surgery, we take the picture of the eye, the iris with the Pentacam, and on the day of surgery, it is transferred to the laser wirelessly, and then it does this automatic cyclotorsion compensation. The liquid, it also has liquid optic interface that minimizes pressure to the cornea, quite similar to the Catalyst system. However, here you can see the difference is that the patient's bed does not move. The surgeon is moving the laser head towards the eye, so it's a little more comfortable for the patient. It also has certain other features such as IntelliAxis for toric IOL axis marking, which are two small notches on the anterior capsule. So you really don't need any other system such as Callisto or even manual marking when you have this system, because you can place your toric IOL onto these IntelliAxis marks. It also has an inbuilt Woodcock's nomogram, which is incorporated in the machine for planning of the AKs or the AIs for astigmatism. And you don't need to do any manual calculation with this laser. Another feature is that it automatically classifies the cataract density, and based on the cataract density, it selects a fragmentation pattern which is suitable for the type of cataract. The Zemer's Femto LDV is the first real mobile femtosecond laser for both cataract as well as refractive surgery, with the highest pulse repetition rate of 2 megahertz and low energy per pulse, and it also has a liquid patient interface. However, with all these advancements, also complications with flac surgery have been reported. Some of them are not acceptable also, and there are certain limitations as well. So I would conclude by saying that flacs is still a young technology compared to Phaco, which is a much more mature technology, and flac still is in the process of significant progress, and we can expect progress in terms of the size of the lasers. They need to be smaller. The new softwares, you need to have more user-friendly interfaces and more efficient and cost-effective versions. And I feel that if adequate improvements are achieved, flacs may one day become the gold standard of cataract surgery. So this was my point of view, and thank you so much for your kind attention.
Thank you. Thanks a lot, Sheetal. That was another amazing talk, and I've really taken off starting with the both dynamic women who have given a great input to us. So let's take some basic questions, and I would expect the expert panel to add any question if that is relevant. Now, how does having a gravity-based system or a hyper-pressurized system or an active fluidics, now how all of these big terms translate intraoperatively to a surgeon? Now, Dr. Mohan, would you want to comment on it, or Dr. Ramurthy to add to it?
I think the intraoperative control, when you have an active fluidics, or the Stellaris Elite has got adaptive fluidics, which is similar to that, is much better, and the chamber stability is better. And even if you have a PCR, you will be able to monitor the intraocular pressure much better. So the active fluidics actually work very well, and the post-occlusion surge, everything is very less, and the chamber shallowing is very less. So depending on the what you call the variation, or what is called the turbulence in the anterior chamber, is also very less. So the active fluidics actually is a very big asset as far as the Phaco fluidics is concerned, in my opinion.
Dr. Ramurthy? You have to unmute yourself.
I agree with Mohan. We have been enjoying the benefits of active fluidics for some time, and Now we also have further updates on this. The main advantage of this is that you are able to maintain your intraocular pressure at near physiological levels of 20 or 30. At the same time, you have the benefits of using higher vacuum levels and higher aspiration flow rates. So without compromising on the speed of surgery, the followability of the cataract, at the same time, you are able to make it more comfortable both for the patient as well as the surgeon. And even if there is a surge occasionally occurs, it is significantly mitigated because the intraocular pressure that is maintained is quite low. And having said that, it's not that that's the only way to go. There is a possibility even where active fluidics technology is not available with the advanced in the peristaltic machines as well as the Venturi systems, which almost mimic each other with the right settings. You are able to get optimal outcomes. I know of several surgeons who use gravity-based fluidics, but keep the bottle height just at the range of about 40 to 50. And today the tendency is not to go for excess of anything, whether it is aspiration flow rate or whether it is phaco power or whether it is the bottle height or the intraocular pressure. Moderate levels of everything, which gives you adequate control at the same time, extremely friendly as far as the cornea endothelium is concerned.
Amal, would you like to summarize it? How, just one liner, like both of them have been more for active fluidics. What about the other companies do not have active fluidics, but they seemingly believe that they are doing very well?
I think I qualified my statement.
No. Yes, Dr. Tamil?
Yes, ma'am. Like sir said that all these advanced modalities which helps to maintain the infusion pressure, so helps to maintain a stable anterior chamber. Hence, the confidence of the surgeon to operate, it increases. So the safety and efficiency, everything becomes good.
So then one simple question. Do you have a particular phaco tip, Dr. Mahipal, which you would prefer for handling hard cataracts, and why do you want to use that?
The tip you are talking about, okay. So basically when you are looking at doing, we normally prefer to do a direct job. And essentially in a direct job, when you're doing, and specifically in a hard cataract, you want a solid hold, a rock solid hold on the vacuum. So we did, so a good combination would be a 15-degree tip, so 0 degree, 15 degree or 30 degree. So if you want cutting ability, that's 45, but 15 degrees is a great tip, and a Kelman bend tip at that would be a great tip. It's about a 30 degree bent or this thing, or a 15 degree, and I use a 19 or a 20 gauge wide bore needle, because when you're using a thin inner bore needle, the fragments tend to get stuck in the needle, and you have times flush it. So that is, so if you ask me, 15 degree tip and a Kelman bend at that.
Everybody should be muted. Satyajit, especially you're moderating, you need to be conscious of that. Then going on to the femto part of it, now that we have different mobile femto platforms with their own different features, so what should a surgeon now choose, like when he's investing in a femto platform? What do we have for our delegates who are watching? Do we...
the recurring cost is the most important thing, the per procedure PI and the CMC. So I think these are the two important things that one would, at least I would wish to, if I was to purchase the machines. That's something important. As Sheetal was saying, I would just qualify that they are no longer in the infancy, they are becoming teenagers now. They haven't achieved adulthood, but things have improved significantly. And the new add-ons like the toricity, toric lens marker, etc., those kind of things are very important. Those are coming in the steep axis, etc. But I think the key would be the price that you are paying for the maintenance of the machine. That is more important than the upfront and the per procedure cost, because when we started, we were charging 50,000 delta, and that was because the PI used to cost us 26,000 rupees, and you couldn't work at lower. As we reduce the costs, for the differential, the numbers have gone up. So the PI cost and the CM3 are important things for me.
Dr. Ramurthy,
Just-
would you want to add a sentence? Yes.
Yeah, I completely agree with my pal. PI and recurrence cost and also a reliable service is extremely important.
Yes.
Somebody with whom we have a good connect. But at the same time, now we have machines available. We have which enables you to do multiple procedures, like the same instrument with which you can handle a cataract as well as do create a flap as well as remove a lenticule. And some of these, as was mentioned by Sheetal, like the Z8 is a mobile platform which can even be shifted from one unit to another. So these are the things that need to look for, because if whatever be the argument for and against laser cataract surgery, if cost was not a concern, it would have been adapted in a much bigger manner. So making the same equipment which can handle different types of surgeries in different places would be the way to go. And I think towards that, significant advances are being made. I think in the next 5 to 10 years, we'll find that single laser platform would be able to handle multiple procedures, and maybe it will also be able to, we'll be able to take it around to different centers.
Can I add something, Chitra?
Yes, Dr. Mohan.
I think as Ramurthy and Maipal were telling, important is the recurring cost and the service backup. What is more important than that is the capex, the amount of investment you're making for initially about 3 crores, 4 crores, or 5 crores, and going for missions like Z8 or something like that. You have versatility of the mission. So you can do a LASIK flap, you can do a lenticule, you can do a lens extraction as well. So all these things you can do. So people who are looking at new technologies like this, I think it's important to also look at the capital expenditure which is involved in this, and which will make life easier for them in the long run. Because if you're able to do multiple procedures on the same mission, your optimization of the mission is particularly useful for your center. And if more surgeons are going to use that's going to make your life much more easier as well.
I would want now one-line answers for this. What should be which one would you feel is the best, the toric markers on the cornea or on the anterior lens capsule? Any one of the three of you? Dr. Maipal?
I don't think any one of us has the capsule mark, because I think that's with lens AR. All three of us have used Catalyst, so they are pretty accurate. I just even in the live surgery number, we were comparing the toric mark. See, the only thing is if we get the Cassini instead of the Cassini, if they are able to link it with the Pentacam, then it is fantastic, I think, because they're easily seeable and everything is good. I can't comment whether
Yeah, I can say something. Yes. So we have the Pentacam and it is integrated with Pentacam. So every patient who is going for multifocals or torics, even for AIs for low astigmatism has to undergo a Pentacam for cataract surgery before cataract surgery. And this data is wirelessly transferred. And as I showed that it automatically compensates for cyclotorsion. So it's very useful for AI planning as well as toric IOS. We don't need to do any manual calculations, no lricalculator.com, because it does everything automatically. It has the Woodcock's nomogram integrated, which also compensates for the posterior corneal astigmatism. So you don't have to do any online calculation. Everything is done in the laser. So it's a big advantage. Also, the toric marks, of course, for toric IOLs. For these cases, we really don't need any marking or Callisto markerless system. So it's a huge advantage, actually.
I think the point, well taken, the point you wanted to make, I think, Chitra, is that whether it's the Varion or the Callisto or the Cassini, they all create markings on the cornea, the overlays on the corneal surface. While Lensar, which she's talking about, is the only equipment which is marking right on the lens capsule. Because of which the parallax error that can be induced when you mark on the cornea and superimpose on the in the bag may be removed. But I think as of now, in our hands, even these systems are working very well. But obviously, it's a way forward to have a marking right on the lens capsule.
And in the post-op period, you don't have to basically assess, because you already have the marking there on the capsule, so you can see the rotation very easily.
But Sheetal, the markings on the cornea are also visible in the catalyst system. So those markings persist. So it's not a question that you don't have the markings. It's only the Varion and the Callisto where obviously that's the digital,
Yes.
that's an overlay. But on the catalyst system, the marks remain.
Okay.
So
You
then
can see
one
in-
last question before we go to the individual topics. What should be expected in the Femto platform as a future development, which would make us feel that we are not in infancy or in the young adulthood or whatever each of us were trying to describe it? Can you all, and I don't want all three of you to say the same thing, different things you can say.
LRCS has reached its puberty according to Mahipal.
Sorry, what did you say?
According to Mahipal, LRCS has
We
reached its
want
puberty.
serious stuff. We want serious
Sorry.
stuff.
Yes.
I'll want to come back with an answer in 5 minutes.
No,
You're
no.
welcome.
What was the question, Chitra?
So she says, what is an ideal? So according to me, if you want an ideal machine, I think lens AR, first is the cyclotorsion compensation, the overlay as regards the toricity, etc. LRI, this is something important. The second thing, what the lens AR does is also a good thing, which is it does the, you can say that is where the application of the AI is there as to the grading of the nucleus and as to what should be the cutting pattern. So I think that also is a good thing that these guys have done. So these are important things from that perspective. Apart from that, I think what I said, I think they have come pretty. See, it's an intuitive thing. If you compare a lens 6 with the catalyst is much more intuitive. So you can just press and you can work on things and the pupil enlargement, etc. So I think it's pretty much there, I would say, as regards the technology, except for these add-ons which are there. Everyone is talking about toricity, everyone is talking about better LRIs, and everyone is talking about AI as regards the nuclear disassembly.
Yeah.
Apart from that, I don't know if Mohan, Ram, you have any other wish list on that.
Oh, just
Incisions are the
what
problem. So I think liquid optic interface, the incisions are all.
Ramu, you're talking? Yeah.
No, just what I'd already mentioned. I think all of us, whichever platform we are using, get familiar with it, become comfortable. I think very minor differences from one to another. To my mind, what will make this technology more acceptable is multiplicity of applications, and that's the way forward. Once you have a machine which can take care of your cataract refractive surgery and also create pockets and intracorneal ring segments, etc., that would be the way to go. And I think there are machines becoming available for that.
Do we discuss incisions? It doesn't make much sense, no? So I'm leaving out the incision part of it from the, because I think it doesn't
No, I
matter
think
which-
we should have some Phaco machines. I'm sorry, the Flacs machines, which can make some good incisions as well. So versatility is one thing which is important. Portability is another thing which is important. Cost, reduce cost. These are three factors I would look at in the future.
So Chitra, there is one more thing which keeps on getting discussed in various advisory boards, which I don't personally believe is a great thing, but a lot of people are saying that the Femto and the Phaco should be in one machine. So that's another kind of wish list of certain doctors overseas, maybe space constraint or whatever it is. So they want to have both the things in one single machine. So that's
Lensar is coming up with the Ally platform, which combines Lensar.
I'm telling you, the US surgeons, I don't know why they have it a wish list, but they are wanting both in the same box.
Yeah, that's not a bad idea at all.
Yeah, I know. So I'm telling you that that's another wish.
It may improve the workflow.
Yeah.
For the surgeon.
Yeah, that's a good wish list. And we shall now go on to the individual topics, and I think a lot more has to be learned there. Thanks a lot, experts, for your discussions. So we go on to the first segment, small pupil, and we have with us two players. I think Dr. Himanshu has not joined in. Mr. Sunil, could you find out about Dr. Himanshu? We would.
Yes, ma'am.
Dr. Suvin, can
Yeah.
you wait on? I think I would rather do both the teams together, unless he's not joining in.
Do we have an idea? Because I thought this would come early, so I've kept some work. Anyway, do you have an idea when he's going to join?
Okay. We'll
So I
just
thought I was
find out
going to
if
go early.
you'll be the next. You'll be the next person if he has not joined in by then. Okay, just sorry, very sorry about that. We have our next to go would be since I have both Dr. Minu Martin and Swapna Nair here. So let's go on to the intumescent cataract. I'm sorry, you may not be might have been prepared, but it's always better to have a team talking. So talking on for my approach in Phaco, intumescent and cataract is and hypermature cataract is our senior consultant in Chaitanya group of eye hospitals, Dr. Minu Mathan, who's a absolutely veteran surgeon in cataract, phaco and refractive surgery. And there's always so much learning. And whenever he has his courses, he has a audience which is packed to learn something more. And talking for Flacs, my approach in Flacs, we have this, again, another very prolific surgeon, Dr. Swapna Nair, who's a senior consultant in cataract and refractive surgery from Trivandrum. And let's hear both of them and learn something valid. On to you, Dr. Minu.
Yeah, thank you, Dr. Chitra. I'm trying to share screen. Is it coming up?
Yes. Mr. Sunil, could you please find out about Dr. Himanshu?
Okay, and thank you for the invite, Dr. Chitra. It's a fairly repeated topic of intumescent and hypermature cataract. But I've been using this Femto platform for the last 10 years now. So, but I've been given the topic of my way in manual or instrumental Phaco in intumescent and hypermature cataract. No financial interest in this. So, any talk on intumescent or hypermature cataract will be incomplete if I don't say that some very occasionally a very intumescent young man or a very young patient, sometimes even with the first stroke, you may get this kind of a split in the anterior capsule. So this capsule extending as an Argentinian flag sign might occasionally happen, although there are different ways of trying to avoid it, which we'll come to after some time. It may happen, but most of them are very soft cataracts and they can easily be aspirated, and the rest of the capsule can be managed properly so that the IOL can be placed in the bag. So moving on to actual intumescent. So in such a case, you'll have this kind of fluidy cortex, and you can always stain the anterior capsule. I will always stain, put HPMC, and over top of it, I put sodium hyaluronate, high molecular weight sodium hyaluronate, and flatten the anterior capsule. And then make a small nick and turn it immediately so that it doesn't become a long linear cut. Once that is done, you initiate the rotation. Once if you see it is going away to the periphery, stop, put in more viscoelastic like sodium hyaluronate, and that is towards mid-periphery, not at the center. And complete the small rexus as small as possible or whatever size you want, but it has to be a complete rexus. So once that is done, you can use either bimanual or a coaxial and aspirate the cortex, the fluffy cortex from the center and also from inside the bag 1 or 2 millimeters away from the rexus margin. Then I put again sodium hyaluronate, flatten the anterior capsule, and then make an oblique nick on the capsule and use your microrexus forceps to complete. Now, actually, it doesn't act like a tense bag. The intralenticular pressure has been relieved by the aspiration of the fluid and the fluidic cortex, which are there in the bag. And these kind of lenses are relatively soft, and there is no big deal trying phacoing this nuclei. So, but nowadays I have started aspirating slightly more, not just within the rexus area, because there is a lot of fluffy cortex in the mid-periphery, and we will be going towards the mid-periphery while trying to extend the rexus. And so there you don't want this one to bulge up. And we should remember that this kind of cortex is there behind the nucleus also. So if we rock the nucleus left and right, some of the cortex from the equator and on the sides also will come out. And most of them can be aspirated. It takes some time. I take some time and aspirate most of it. And after that, you don't need very high molecular weight viscoelastic. Just the chamber has to be filled up, just like in any other case, and the capsule behaves just like any other case. So you can use micro scissors and make a oblique nick like this, and then proceed on to the size required for the type of nucleus. Some of these may be very hard nuclei also, but there is a talk coming up on hard nuclei, so I don't want to go into details of phacoing hard nucleus. And similarly, make a nick and go around. Can use the paracentesis also. and re-grasp it as many times as you are comfortable with. 1 to 2 strokes may not work with many people, but then every 2 clock hours, we can easily re-grasp the flap and then finish off a complete adequate rexus. So once the rexus is complete in intumescent cataracts, the job is more than 90% done. So these kind of intumescent lenses may move on to this phacolytic situation also. So rarely some patients come up, depends on the places where you're practicing. So you can see that there is corneal edema even after mannitol and all those. And once you take out the fluid cortex, this is one trick which I use. The spud which is wet, if it is rolled over the cornea, it instantaneously becomes clear for some time. Later we may have to redo it. Here I'm doing an SICS. Some cases may be safer to do SICS in my hands. The other problem which you face will be calcification on the capsule like this. So here I'm trying to avoid the major calcification and going around it. But there are some in the periphery also. So if you run into them, there can be difficulties, which I'll show later. But most of the times you are able to finish it off. And this is a very small nucleus which can be evacuated like this, and the IOL is placed in the capsular bag. But in some cases, with a lot of calcifications, and some areas, you may tend to lose a rexus. Here you can see a rexus extension here. So ideally, first thing to do is to take out iris hooks and expand the pupil and see very well what is happening. And then, because there are the nucleus seems to be bigger than what I expected. We expect very small nuclei in these cases, but then see, this is almost 7-8 millimeter sized large nucleus and is firm hard nucleus. So I make few nicks on the margins of the rexus on 3 or 4 other locations, so that the pressure, if ever is applied in the bag, is not transmitted to the only single cut which is there on the capsule. And my technique will be to hold on to the nucleus and pull one pole of the nucleus out of the bag and do the lateral separations outside the bag. So here you can notice that the pole which is out of the capsular bag is being split. So we can hold the nucleus with the second instrument to keep it steady, and then use viscode liberally, repeated multiple times, because the phaco is happening a little above the iris plane. But it can be retained under the iris also, and gently we can do the splitting because you need not be afraid, because it is outside the bag. So a lateral split need not be very controlled or very gentle one, because in the bag and not any pressure in the bag, then out of the bag. So here I make complete the peripheral chops and finish piece by piece, make the smaller. You can notice that it decreases. I don't insist on a complete chop immediately in the first shot or second shot itself. The center may, and after some time you'll see that the sizes, and it can be easily emulsified at the end, because the central rhetoric part may not split always in 1 or 2 strokes or chops which you do initially. Later on, it can be even flipped up, and you can go to the center and split the nucleus. So some of them are hypermature, going on to the hypermature Morgagnin types. So here, one nick, the fluid will come out. It may not be under very great pressure, so it may not extend to the periphery. So here I am using, you can use either a separate cannula or the same cannula which is made into a cystitome to aspirate what has come out. And again, fill up viscoelastic and remove all the fluid cortex which has come out, and visualize it well, and do an appropriate sized rexus, which is possible here. Many times it may not be possible because of the very loose bag. But here, notice the size of the nucleus. It's so small. It's difficult to hold in this kind of some kind of these cases. And so here, the technique, I think I first heard it from Dr. Debashish. You can either prolapse this nucleus out and keep it in the sulcus and place an IOL into the capsular bag. But here it is so small and the pupil is so dilated, you can see the bag very well. Sodium hyaluronate fills up the bag. You can tilt the lens a little bit and get the IOL into the bag. Now, advantage is that the PC is far behind. Nucleus is not mobile because the bag is more full, and you have protection all throughout your surgery from this nucleus moving around, or the phaco tip or the chopper touching the PC. So here these are not very hard ones. They are brown ones, true, but you can easily hold them and chop them, split them. But this is also done within the bag or within the pupillary level itself. So need not worry too much about the endothelium, but always use Viscoat or sodium hyaluronate plus chloride sulfate combinations, which are available in from Indian companies also. And lastly, there are hypermature sclerotic kind of cataracts where the nucleus becomes very hard and there is no much of cortex, but there is calcification at the capsule, underneath the capsule. Sometimes it will be free, sometimes it will be involving the capsule. So here now you can see that I've run into a large area of capsular fibrosis. So here I try to come from the other side, try to extend with the forceps, the capsulotomy needle. We should better go for the forceps and try to make a nick beyond it and try to get the flap go around the large fibrosis which you see there. Sometimes we'll be able to get around it, but sometimes it will be extending till the equator. So many times you may not be able to do that. And if you pull too much, you may pull the bag, you may pull the zonules also. So some will be having associated zonular weakness, but I'm not going into that because a subluxated cataract talk is already going, it's following. So identify areas of capsule which are free and they can be gently teased out, but the easiest way will be to make multiple cuts with your micro scissors. That will be easiest because they don't tend to tear off. So cuts made, although they may look a little irregular on the edges, they do not extend to the periphery if they are cut within the capsular fibrous area. Here you can notice that the fibrosis is also cut and we have got a almost complete looking, although there are cuts in between. So here the nucleus is so large, but then still we were able to complete the phacoemulsification and the bag margins held very well and did not tear to the periphery. So thank you very much. That's what I could cover in 5 minutes.
Yeah. Thank you very much. You covered it all. You did a great job of it and lot of information. We shall now go on to our next speaker, Dr. Swapna Nair, who's going to be talking why she would choose Flacs for Intumescent cataract.
I hope my screen is visible, ma'am.
Yes, yes.
I'd first like to thank Chitra ma'am for having me here. She's very sweet with me as far as presentations are concerned. Anyway, so I think, I believe that Flacs is one technique which benefits any patient with hypermature cataracts a lot. And that is especially because we have a capsular axis that needs to be perfect in Flacs, unlike any other form of cataract where it can be easily achieved. And of course, there's a question of nucleus disassembly in a slightly harder cataract. So this is the dream kind of capsular axis you can get in a hypermature cataract, which is of the perfect size, at the perfect site, and of the perfect shape. But this comes with a lot of, specific instruments that can achieve this kind of a feat, and with a lot of high density viscoelastics. Now, if you don't have access to that, then most of the time it runs to the periphery. If you don't use your viscoelastics wisely, then once it starts moving, it's very hard to control. Especially there's a lot of maneuverability involved in, trying to fold the flap on itself. And when it doesn't happen at that side, going to another site and getting a semi-lunar rexis. So there's a lot of dynamics actively involved here. Or sometimes you may end up with a very small kind of a rexis, which puts a great stress on the zonules. So basically, we are talking about a cataract which may have weak zonules, because weak zonules are usually associated with such kind of cataracts, increased intralenticular pressure because of the fluid cortex, and a dense nucleus to top. And with all the maneuverability involved in dealing with a hypermature cataract, you may have a rexis runoff. If that is coupled with a zonular dialysis because of all the maneuvering, you may not be able to put a lens of your choice at the right position. And all these maneuvers inside the anterior chamber can lead to a lot of endothelial cell attrition. Now, of course, you can try to bring back an extended rexis to the center, back again, and try to complete the rexis. But many a times, if the surgeon is a novice or not very experienced, this may not happen. So as a surgeon, what you need is consistency. And consistency means a free-floating rexis in all imaginable types of cataracts, whether it be a low density or a high grade nucleus. If you have a rexis that's perfectly round, fits the lens all around, covers the edges well, and, centers the lens well, I think that is what should be aimed for. So towards that end, such a rhexis is possible in a hypermature cataract when you're using the Femtosecond platform. And to top it, an additional effect that I've often seen while using such while doing surgery for such a cataract is that sometimes you get nuclear grooves. In most of the cases, you do get nuclear grooves, though they may not be clear chops, but you definitely get planes along which the nucleus can be well separated by a direct chop without, putting too much strain on the zonules. So I guess that's an added advantage even in a more opaque cataract. But special care needs to be taken regarding certain aspects when you're dealing with femtosecond laser in a hypermature cataract. First is the liquid cortex. So as soon as the capsulotomy starts, you get an ejection of the liquid cortex into the anterior chamber. And this prevents the laser pattern in the rest of the capsule. It may obstruct your nucleotomy. So that has to be kept in mind while doing the procedure. Now, towards that end, I think the PI is a very important factor. So liquid PIs tend to do the capsulotomies faster, so that the whole of 360 is covered in one go immediately before there can be undulations, before too much of fluid spreads into the anterior chamber. Besides that, appleniting PIs, like was mentioned earlier, tend to produce some kind of posterior capsular folds where you need to apply more energy to get the capsulotomies. Though that is not very common with the soft fit, but that still should be kept in mind when doing a hypermature cataract. Then capsule offsets. That is very important. We know that the anterior lens capsule moves quite a lot when fluid comes from behind the capsule into the anterior chamber, and the range through which that energy is supposed to pass needs to be increased from an offset of around 200 microns to approximately 900 microns or so to cover that range of undulations produced by the capsule. So if all these patterns are followed, then most of the time you end up getting consistent results. And fibrotic capsules, of course, you should always keep in mind that there will be gaps in capsulotomies that may need to be completed manually or using micro instruments. Now, even if you get a partly attached capsule like you have in this case, always remember that nearly 5/6 of the capsulotomy is completed. And if you follow the same curve, it is so much more easier than doing over a virgin capsule, because the fluid has already spread away. There's no intralenticular pressure, and the surface of the capsule is perfectly smooth. It's not, going downhill towards the periphery, which usually leads to a capsular tear. So even in such adverse circumstances where the rhexis is incomplete, having a large amount of partial femtorhexis definitely helps in completing that rhexis to the optimal end. So I think this is the basic way in which hypermature cataract is assisted by the Femtosecond platform. Thank you very much.
Much, Dr. Minu and Swapna. They were both great talks. Can we go on to the expert panel discussion? Now, we have Dr. Mohan and Ramurthy as the expert panel now. Mahipal is out for a while, but any of the other speakers are all very capable. Could chip in, and you could just raise your hand and we would take your discussion. Now, as far as the Intumescent cataract is concerned, what could be the reason for getting those rhexis extensions with flacs? Have we thought of it? We know we do go in for doing a femtorhexis, and we constantly believe that it's going to be nice and round and sure. But we do sometimes get a rhexis extension. What could be the reason for that?
Can I answer that?
Yeah, can I
answer that?
Yes,
Yeah, no problem. I think the most important thing in a femtorhexis is that many of the times in Intumescent cataract, that's what in a femtorhexis, when you do a flacs in an Intumescent cataract, is that many of the times it's free floating, but many of the times it can also have skip areas. So don't try to pull this capsule out, just like you do it for an immature cataract. So if you try to pull it out, then what will happen is the tags will be there, and these tags can extend across the equator into the posterior capsule during your phaco emulsification. So what I do is always stain and look at these skip areas and look and do a, just like you do a rhexis, you use a Utrata forceps and try to manipulate that area where there are small attachments. And always you, when you do the femto, the rhexis, in the Intumescent cataracts, go for a little more energy and go for a little more offset, and that will make the rhexis very easy. In catalyst, it works wonderfully well, but I am used to that system, and in the rhexis is very fast as well. You need to be fast. You don't see, the thing is, in all the manual things and manual rhexis, you are giving time for that nucleus to come forward, and there is a pressure in front of the posterior capsule to push it forward and produce an Argentina flaxime. Whereas when you do a femtorhexis, it's so fast, and it takes only 1.4 seconds or 1.5 seconds or less than 1 second. Also, if you want, we can make it very fast also. And because it doesn't give much time, it opens up the 360-degree rhexis with no time as well.
Chitra, if I would,
If it's a decentered dog,
correct.
if it is a decentered dog, you could get an incomplete capsulotomy. So that is one thing which I wanted beside the skip area point which you offered.
Yeah.
And the
One
other
more
thing,
if I,
yes.
yeah, Chitra, if I could say, some even if it's not a very intumescent, certain patients, short, chubby, bull neck, big cataract, the nucleus is pregnant. I have got a rhexis, just a small incomplete one, even in a regular femto, not just necessarily this, because the cataract just wants to burst out. You asked, why is it that in a cataract, a intumescent cataract with a femto, why does the rhexis run off? Because one, it could be a little angulated, as you said, a little decentered one. Two, because the material comes out so fast, by the time you're getting off, it just extends. I've had a tear going off an Argentinian flag in a closed chamber with a femto. And there are times.
Yeah, I agree. Could it be that if we play around with the vertical spot sizing, we could speeden up the laser thing? And what do you say? Yes, Dr. Himanshu, what do you want to say?
Offset, as he said, one thing Mohan said is
offset.
Two, one more thing, with a capsule like this in a white cataract, keep the blue rex in for a little longer time, because quite often, you are in a hurry to push in your viscoelastic and get on with the capsule or rhexis. It doesn't stain, and unfortunately, the area which doesn't stain is exactly the area where you want the stain to be there. So the offset, and I have got bad luck at times. The cataract you might have seen in a shallow anterior chamber with a big cataract. When you see it on your OCT machine on your femto, the lens is just about to explode. So part of the capsule just goes to the periphery, and it's just beyond your control, despite it being in less than 2 seconds, 2 to 2.5 seconds.
What are your pearls for? What are your pearls for getting a sure complete rhexis in femto? Although we know because of the speed of the rhexis, we are going to get a complete rhexis, and we have the right energy settings and offsets. But what else do you think, does it make sense to actually think of decompressing the vitreous by managing them medically before we take them up these cases? Just a thought.
No, if I might say, as far as getting the rhexis contours right, most of these capsulotomies are contour guided in some form or the other. So even if you have a slightly decentered dog, there are mechanisms within the laser which takes care of that slightly decentered dog. And if it's grossly decentered, of course, you cannot proceed with the procedure. And the reason you get a rhexis runoff in these situations is, as Himanshu was mentioning, in these highly intumescent cataracts, there is a sudden fountain of fluid which is gushing out. And when that comes out, because of the pressure of that, there is a tendency for the rhexis to run off to the periphery. That's the reason this incidence is a little more in cases where in the machines which take about 6 seconds to create a rhexis, compared to the machines which create a faster rhexis in, say, 1 to 1.2 seconds. So that's one of the reasons that they say that it's an intumescent cataract, but not a fibrosed capsule. That's an issue. Maybe even reducing the offset is a good idea, because so that you get a shorter time duration where the laser action is there. Laser starts in the posteriorly and moves forward. And if the time taken is less, the tendency for this runoff is runoff is likely to be less. Having said that, all these cases I always stain with trypan blue, but most often you're not even sure where exactly the capsule is. So you can't just assume that the capsule is there. Sometimes you see free floating in one in the angle, but sometimes there are skip areas. And as was mentioned, you have to, but still you have a template, a nice template which has been created. And just like you would create a rexis, you can follow the usual steps and complete the rexis.
There is magnification of the this thing by the offset, which needs to be increased if there is fluid egress. That if the lack of that is magnified by the docking problem, because even in a regular cataract, we sometimes see that the rexis takes a particular pattern as if it is going circumferentially from one end to the other, but we all know it is simultaneously happening from the posterior to the anterior side, though different parts appear to get rexed at different times. Now if there is decentration added to this, then it is overtly magnified, because then the capsule is at different levels, and unless the offset is great, then that cannot be controlled.
So one thing that I would say, Chitra, is one more just addition, a small point. If you are decentered, your original understanding, the algo of the machine does not place the rexis at the right place. The lesser the manipulation that you do on the machine and the lesser the offset that you have, that is the best way out. If it goes smoothly, it will go fastest when you have least manipulation on your machine that you've done. What I'm trying to say is, when you decentered capsule or rexis and you try to center it, or you move the other parameters, it kind of takes a little longer time. And there are times when it goes like a laser. And so that's what I would say, decentered docking and not too much of movement that you should be doing. You could redock again.
One question to Dr. Mohan and Ramamurthy. Yeah. Would you think of adding a CTR in a hypermature cataract? Your take on that? And anybody in the speakers, next question I would want to know is your thoughts on using a MyLoop in a hypermature cataract, or doing an AIOS scaffold. Your thoughts on that?
CTR, unless there is a zonular weakness on the table, I would not use regularly for these patients. And I don't have any experience with MyLoop, because my results with Flacs and hard cataracts are pretty good, but even for the brown, black cataracts as well. What is the third one? Morganian cataracts, then probably, I think I showed a video in Amritsar as well. And I would probably use IOL scaffold, because these nuclei are a little small. And once you have an IOL in the bag, then it makes life easier for you.
Yeah. Yes, Dr. Rohit?
Yeah. MyLoop for hard cataracts, as you have asked, I believe that, the most important factor, one of the factors is that you have to have, protect the endothelium by all means. Because in these hard cataracts, endothelial protection is a very important factor. With MyLoop, I'm not using MyLoop. I believe because you can only create 4 pieces. And those 4 pieces, when you're trying to emulsify them, they are too big and they can cause larger insult to the endothelium. The basic concept of having smaller pieces and keeping them under control and emulsifying is the concept when we have to do hard cataract phacoemulsification. So MyLoop does fragment, but it doesn't create smaller pieces which are obligatory and mandatory for very hard black cataract phacoemulsification.
Both Satyajit and Anaka, please, at any
please,
point
cataracts
raise your hand and take questions, please.
Chitra.
You'll be most welcome. Yes.
Yeah, I fully agree with Rohit. But these cataracts are very huge cataracts. Please understand. And
yes.
When I use a Flacs, I use octants. So I go for 8 pieces, and further the 8 pieces, I make it into even smaller pieces to get them out. Because if you're going to make it bigger pieces, and if you're going to emulsify the bigger piece in the pupillary area and anterior chamber, you can have a white cornea the next day. So the smaller pieces, then you can be entirely in the bag, and you can have a posterior plane phacoemulsification, which can result in a very clear cornea in the postoperative period.
Yeah. So we go on to the next set of talks. I'm sorry, Shreyas, since both Dr. Suven and Himanshu are there, it's going to be that talk. I had misinformed you. We shall now have Dr. Suven Bhattacharya, who's a senior consultant from 9 Eye Center, Kolkata, and a truly amazing surgeon and an innovator. And we know that the BX ring has gained worldwide popularity with the ingenious thought process of Dr. Suven. And we have with us Dr. Himanshu, who's again a senior cataract surgeon from Vision Eye Center, Mumbai, who operates only on the VVIPs, I believe. So with some top people talking on a complex topic, I'm sure we are going to have lots to learn on how to be very safe in a small pupil. So Dr. Suven is going to talk on Phaco and his approach in small pupil. On to you, Doctor.
Yeah, thank you very much, Dr. Chitra and the entire ARC team for this invitation. So we'll be discussing my approach to small pupil in Phaco, and we would like to take care of both pre-op non-dilating pupils and intra-op meiosis. I do have a financial interest in the BX, whatever little I speak about it, and I do acknowledge Dr. Deepak Magor's contribution. I hope my screen is visible.
Yes.
Yeah, okay. So I look at very objectively pre-operative considerations, intraoperative considerations, and post-operative considerations. So if you look, we are mostly concerned about the comorbidities that may also affect how the people behaves. So we would like to take that age into account, diabetes, hypertension, cardiac disease, medications, because now we know there are a host of conditions which cause IFIS, and it's just not tamsulosin. And of course, uveitis, glaucoma, and pseudoexfoliation and other eye surgery, the previous eye surgery, that is. And I would like to prefer to actually note it down, especially in facilities where there are multiple surgeons. One person takes the history and examination, another person does the surgery. It's imperative that we note it down objectively. Now, that is the list of drugs that can cause IFIS and conditions. So no amount of history taking can prevent surprises, but then definitely we could be better prepared. So that would serve in useful, but at least you have the backup and plan B in position. So there is a question which I always pose in all of my talks is, what is the safe pre-op pupil size to eliminate the risk of IFIS? This paper in 2011 pretty much told us that for a pupil 7 millimeter or smaller, the risk of IFIS existed regardless of alpha adrenergic receptor antagonist treatment. So that's 7 millimeters. And for those of us who think that IFIS is not a big deal in India, well, it's the risk, the incidence of tamsulosin intake and IFIS is much higher. And it has been documented that this is a wonderful paper. It's a landmark paper over here. And that these are important. Hypertension also is an important risk factor. This is, again, another landmark paper by Chang and Campbell in 2005. What we probably, a lot of us miss to read between the lines is, unlike the non-elastic, this is stated over there, exactly picked up from there, unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So now, that means there is something called a rigid pupil and elastic pupil, and the problem is that it's in the cusp in between and traverses all these three entities. So the elastic pupil is very much like a rubber band, it's stretchable. Any expander will work. Now, the rigid pupil is very much like a string, and it is not stretchable but tearable. So you need a strong and bulky pupil expander or a Kuglin hook or something bimanually to tear it. I would divide my strategy into preparation and implementation. So pre-op in NSAIDs, there is a lot of literature which supports that. If you like to use it, every eye is an IFIS candidate as far as I'm concerned, until it's proven otherwise. So release posterior synechia, more importantly, the total posterior synechia and peripupillary membranes, intracameral injection if that's your choice. And I would like to actually most importantly distinguish between the elastic and non-elastic pupil, and we'll come to that very soon. So when it comes to implementation of my strategy, I look at the elasticity and choice of pupil device. So whether I would go for OVD or iris hooks or pupil expanders, viscoimidriasis, I would suggest, should be used very judiciously, and you should have a plan B in position and activate it whenever required. And now we have a choice of iris hooks, pupil expander, and post-op medications to follow up. So from that paper from Chang and Campbell, we know that pupil stretching is not effective in IFIS, which is an elastic pupil, and controlled stretching before the expander is probably helpful in rigid and fibrotic pupils. But then there is a lot of common ground between the two, so that can make it very confusing. So we have among devices iris hooks and the pupil expansion rings, the Milligan ring, the BX, and there are many more in the market. A word or two about IFIS. There are two components, the meiosis part and the iris prolapse. Now, I believe that iris hooks and pupil expanders work very well. They provide a constant pupil size, good visibility for safe phaco. Now, iris prolapse pretty much depends on the IFIS severity and the pathological damage to the iris. So no device actually helps. If you have not had iris prolapse, it's just that your lucky day that it was a lower grade IFIS. That we must bear in mind. So how would I check elasticity of the pupil? Look at the video here. You inject BSS as soon as you do the paracentesis, and you see that pupil expand. And that is an acid test that that pupil is stretchable, it's elastic. Now look at the video on this side. This pupil, you can inject as much BSS as you want. That pupil does not budge. It's not the Sine case, just the rigid pupil. See that fibrotic membrane. Now you do that stretch. And once you've done that controlled stretch with two Kuglen hooks, you have a reasonable stretchable pupil. You converted it more into a stretchable and a cosmetically more appealing pupil. So a favorable device in IFIS would be something which requires a small incisions, is thin and low vertical profile, and can exit through a side port. So the choice of pupil expander would depend on how you wish to tear the rigid pupil. It's a very personal choice. And so with two Kuglen hooks, it's controlled tear, a BX or any other thin device would be, it occupies a lot less space and helps in easy movement of instruments. Now, when you do it with a pupil expander, the problem is it's a little bit of poor control and you might have asymmetric tears, the Mulligan ring or the APX or the eye ring. It's a little bulky and occupies more space in the anterior chamber, but that's your comfort level, whatever it suits you. For a subluxated cataract, there is no two opinions about it. I would absolutely go for iris hooks because it allows me asymmetric pupil expansion in the quadrants where my subluxation is there, and I can play around that and add as many or remove as many as I want as the surgery progresses. Intraop meiosis, again, I believe iris hooks and the BX would be the ideal choice. So the advantage over here with these two sets of devices is that you can safely engage the pupil margin without catching the capsular axis because you have instant confirmation as you engage the pupil margin. And the control is at the site of the crisis. That's the pupil margin. This is something I always show, that I would like to inject viscoelastic under the pupil margin and elevate it and keep that anterior chamber a little shallow. And that overfilling actually can be counterproductive. So that is an important message that I would like to convey. Nothing against iris hooks. I have contributed significantly even to the development of iris hooks. Madhu Instruments is the largest producer of iris hooks as of now, not only in India, probably globally. And Amit would be happy to tell you how much I've contributed to that. But that given, I would also say that there are certain downsides. There is a risk of infection, and there is a sphincter tear possibility, and the corners are absolutely wasted spaces. We really don't need to do stretch as much and waste those corners. The iris plane, the pupil plane is raised to the limbal plane, and that may cramp you in the anterior chamber, especially with the shallow anterior chamber. You might have a tough time and may cause iris trauma and endothelial damage. There is a paper which suggests that iris hooks take more time than pupil expanders, but then again, depends upon how comfortable and how long have you been doing either. So probably in India, the time taken is pretty much the same. There is a possibility of certain marks on the iris and disfigurement of the pupil margin. The BX has been validated over and over again, and these are the papers in JCRS and IGO, and it's on some other international journals. So how big do you want the pupil to be? That's another question. The hard cataract, we want it to be as big as possible. Why do we want it that way? I mean, any device that gives us an assured 5.5 would be good, because we are all very competent surgeons to do a cataract through a 5.5, given the fact that it will not come down more than that. So a pupil device should just achieve that. Let's look at this video from Deepak Megur. This is a rigid pupil pseudoexfoliation hard cataract. That's where we started. And BX, which provides you nothing more than 5.5. You just can't get more than 5.5. Try whatever you may. So you may make it a little oblong and get a little bit more than 5.5 in one particular axis, but then overall the circumference, that's given with every pupil expansion device. So, and that's a pretty hard cataract, as you saw, and it's not a big deal. You can chop the cataract into as many fragments as you want. Intraop meiosis. Now here it becomes a little tricky because the capsular axis margin is there and you really don't want to engage that. So when we inject viscoelastic under the pupil margin and separate that, lift it off from the capsular axis, that rim of capsular axis, With a thin device, you can, and which with the control of the pupil margin, you can actually push it under the pupil margin and over the capsular axis and actually have instant confirmation by pushing it more to the periphery. And if you have not engaged the capsular axis margin, you are absolutely sure that you've not done, because you're seeing it. With other devices which are remotely controlled, it's a little bit of a problem. Femto laser, this is something which was there in the publications earlier. This is 2015. All femtosurgeons over here will kind of, mostly I think they will say that this does not happen anymore. I think it's open to discussion. Incidence of stereophakic cystoid macular edema is known to happen with use of any device for pupil expansion, compared to when nothing has been used for device, and it was a well-dilated pupil. So there could be multiple reasons for that. I would like to follow them up with closely for a little bit, any signs of uveitis and probably a possibility of CME in the post-op period. So the important take-home messages would be, I would like to identify pseudoexfoliation and associated comorbidities. I would like to differentiate the rigid and elastic pupil. And it's not the size of the pupil, it's the elasticity which matters. We must lower our threshold for using devices. It's not a really very pleasant situation if you land up in a problem just because you chose not to give that extra 30 seconds or 1 minute for a surgery, because that can cost you very dearly and cost you another half an hour. IFIS is associated with alpha blockers, hypertension, and many systemic diseases. And I believe strongly that iris prolapse in IFIS depends on the severity of the IFIS and not really the pupil device. And always have iris hooks or pupil expansion devices in the OT. Whether you choose to use them or not, at least you should have a plan B in position. I would strongly encourage everyone watching to read these 10 tips in phacoemulsification in small people. It's pretty exhaustive. Thank you very much once again, Dr. Chitra and the ARC, for this wonderful opportunity.
That was a wonderful talk, a superb talk, Dr. Suven, and you managed to.
Thank you, sir.
3 cheers to you.
Thank you.
We now go on to Dr. Himanshu, who is going to tell us about flacs.
Thank you so much. Suven, as always, brilliant. There is no question. Friends, for the other ones who are watching, Suven needs no introduction, but every word which he said is golden. His depth of knowledge, his understanding of the subject, from the myotic pupil to the adrenergic receptors, to what he said, 5.5 pupil. Believe me, it's worth every word to listen to it again. There's a lot more to digest between the lines also. Thanks, Suven. It's a pleasure always to share the stage with you.
You have
Thank
5
you, sir.
minutes, Dr. Himanshu.
Yes. Is my video seen?
Yes.
Okay.
Yes.
1 second, I'll just start. So small pupil, as he said, is definitely a great challenge. Never hesitate if you have to use a pupil expander. It changes your full dimension of life. Problem thinking, solution, be ready with your standby plan. And with more and more aging population and more people on antihypertensives and tamsulosin, you are going to get this. What has to be considered? What is a small pupil according to you? And most phaco surgeons are so confident doing at the spinal level that they choose to ignore that. No, I can manage a small pupil. Don't get overconfident, because you can get into big trouble. And as Suven said, it might just give you trouble in the long run, and what might take 10 minutes will take you 1 hour of sweating. So don't compromise on that. However, as he mentioned, I'll skip through this fast. Iris atrophy, iris dilator, sphincter muscle atrophy, metabolic changes, uveitis, angle closure, glaucoma. What are the patients where you have a bad pupil, IFIS, shallow chamber, bad cornea, bad angle? This is what I want to discuss further. Where you are in real trouble, you know what you've done every possible thing. You use your medications, you use your heavy viscoelastic dispersive, you've done your synechial lysis, you've done your stretching technique, you've done everything possible to see that the pupil remains as a good boy, but the iris starts dangling, and God forbid if the phaco probe takes a part of the iris, you are in trouble. It's magnetic iris after that. So you have to be careful, you have to keep moving, get your stuff, and you have good medications available now to get so that the pupil can dilate pretty well. Despite all that, you may still have trouble. So this is what we are going to be talking about. Use them freely. There is no problem. There is not going to be an issue if you use them. Don't let your ego come into the picture. Decreased visibility. That always that hope that to save that 2 minutes of putting in and spending that little extra money to put in a dilator. Don't worry about that. If your rexis suffers, your whole surgery will suffer. So remember, first thing, rhexis is 80% of the surgery done well. Your decreased visibility is always a difficult, your glow will not be good. So difficult hydrodissection, irregular pupil shape and posterior synechiae. So be calm, be clear what you want your game plan to be. Don't be in a hurry. Once your viscodilatation is not happening, Suven has shown you what to do. If it is happening, well, good for you. Synechial lysis can be done. You've gone through that. You stretched your pupil, you tried your best possible stuff. You used your pupil expanders that you have Suvens. But despite that, you have a bad AC, you know what is happening. Now here you see a lovely thing. Your anterior chamber depth is 2.43. You have a small axial length of 21.71 and with low endothelial cell count. This is where you're going to get into trouble, and you really want to start on a good note. As you can see, the angle is bad. You have a terrible angle. You know there is very little space to work in. And look at that. Now the next one, as you do your OCT, you realize while doing your femto, the angle is almost closed. The chamber is flat. And that's where your trouble starts. You know, that's where you have to be thinking and what to do. Here I'm talking about a femto. You have a small pupil, relatively easier. You can do your rhexis to start with. And you see how big the nucleus is. You can see here how big the nucleus is, almost going up to the retina. But first, when you have had a good rhexis happening with your femto and the cataract been broken into good amount of pieces, it has given you a way good head start in life. I'm not saying all your trouble is over. As you can see, the cornea is hazy. There's a big arcus. You're not very happy. The pupil may not be very nice. This is a one-eyed patient. You need to get out quickly. You need to have a lot of tissue respect. But if you have a pre-chopped nucleus, like what you have, you've done your toric part, you've got your stuff fixed. Here is a case which is very interesting. As you see how bad the cornea, this is a one-eyed patient, bad arcus, small pupil. You see the cataract here on the other side, how big it was. Look at the angle, absolutely close. Look at the chamber, absolutely shallow. And this is where we have to plan. We need a good head start. If you can manage to get a rhexis, a foot into the door syndrome, you get your foot there, you put your towel there without putting in any kind of pupil expanders. If you have a smaller pupil than this, you could use a pupil expander even before doing your femto. And that is what can help you. You got your adjustments going, you see to it, look at the cataract, look at the posterior thickening there, you have a subcapsular area, because here the epinucleus is also very thick. And you know you're going to be struggling it out. But at least once you are ready and you got your rhexis there, you can always increase it later. The nucleus is being broken into, what you can see there now. You see how the cornea is so dull that the moment you start getting in, it's a question of time before the cornea can become white in front of you. Having had a decent rhexis and hopefully the cataract giving me a few cleavage spots, my energy would be a little better. So here is a rhexis which is done. You got your dispersive, you got your stuff going. At least your rhexis is over with. Though despite a small pupil, you go ahead, you can hydrodissect well. See that, because here you can have a lot of capsulocortical adhesions also. But as you can see, I have a pre-chopped nucleus which helps me. And first is to debulk. Start debulking. Don't wait to break into multiple pieces. As you debulk, the chamber starts forming. The pupil becomes a little bigger for you. Your bag starts going down. You have more place to work in. So as you debulk, once your rhexis is there, you have removed the capsulocortical adhesions. Look at the epinucleus. You saw the capsulocortical adhesions which would be having. Well, that is where it makes life a lot more easier for you when you have a pre-chopped nucleus. And of course, whenever you have in doubt of ring it out, no question about it, put it in and get moving with it. Do not hesitate putting in a ring at any given point of time. It keeps the pupil equally safe and sound. It doesn't give rise to sphincteric tear. Your full area becomes a lot more easier to work with, whichever ring you decide to use, whichever stage you decide to use. Even if you have had a rhexis and the pupil goes down, as Suven showed it earlier on, it's not difficult. You have to be careful not to get the anterior capsule there. But look at that, suddenly your view is a lot more better and you can go ahead and do it. This was the ring and you can go with it. So this is where I wanted to say how we could be a little more safer in multiple cases where you have an extremely tough case, the pupil is bad, one-eyed patient, bad corneas, bad arcus, endothelial cell count, very shallow anterior chamber, very little place to work with. But you had a pre-chop nucleus, you have access to your nucleus. Start debulking, getting it off slowly, steadily. If the pupil goes down, you still have time to go in ahead and put in your expander. If you feel the rhexis is small, you can always increase your rhexis size after that. But once a good start and a beginning, because if your rhexis in that shallow AC goes haywire and you have an Argentinian or whatever, God cannot help you also. That's where my talk would be how to have a great start, then your skills to expand on as the stage progresses. I leave it to the house.
Thank you very much. Mr. Sunil, thank you very much, Dr. Himanshu. Both of you gave a lot of information on small pupil. We take just one question with the expert panel. And Mr. Sunil, you need to tell at 4 minutes, please, loud and clear. We
Yes,
have a
ma'am.
whole set of speakers and we have to do justice to them. We're running really beyond time. So one question to either Ram or Mohan.
Yeah.
What would be the threshold of rhexis, Dr. Ramurthy, in case of a small pupil? Like, when would you decide that you will not do a flax in a small pupil?
I always want to discriminate between a small pupil phacoemulsification or a small rhexis phacoemulsification. You know, when you have when you're doing a manual rhexis like in phacoemulsification, then even if you have a 4 millimeter pupil or a 3.8 millimeter pupil, especially if it's a soft cataract, after staining the capsule, you can run the rhexis under the pupillary margin and create even a 4.5 millimeter rhexis, and you can go ahead with using the appropriate settings to manage the entire phacoemulsification. Having said that, if it's a case of IFIS or something, then I would always go ahead and put a device, as Suven has eloquently demonstrated, to go ahead and control the case. And yes, he has also said that we have to remember this always. Putting in a device only expands the pupil. It doesn't prevent iris from collapsing through the side ports or through the main incision. As far as if I'm doing a laser cataract surgery, then putting in a device and then going ahead and applying the laser is something I do not do, simply because I believe that the laser is always an semi-sterile procedure and the risk of infection is always there. So I would not venture into doing that, though I know that some of our colleagues once in a while attempt to do that. My cutoff as far as doing a rhexis in a small pupil situation is concerned using the laser is about 4.5 millimeters. If you are using the LensX platform, you are able to make your rhexis about just 100 microns away. But if it's a Catalyst platform, the default setting is about 0.5 millimeters offset from the pupillary margin, which makes it about 4 millimeters. In these situations, you have to go ahead and do a pupil maximized platform and manually expand the rhexis that you are doing so that the offset is just about 100 microns away from the pupil margin. So you end up with almost a 4.8 millimeter rhexis in these situations also. So 4 to 4.5 millimeters would be my cutoff before I decide not to go ahead and use the laser platform.
Dr. Mohan,
Yeah.
if it's a polar cataract where you expect there could be a PCR and it comes as a small pupil, which expansion device would you prefer? Like, if you think in this surgery you could have a PCR and have a small pupil,
Doesn't matter. Whatever expansion device you are comfortable with, I use regularly iris hooks in these patients. My cutoff as far as the small pupils is concerned, Ramurthy, is about 5 millimeter, because I can go about 500 micron less than that, which is about 4.5. I'm comfortable with that. Advantage of having a small, doing a flax in a patient with IFS is that your rhexis is already done. And another advantage is that the catalyst cuts beyond the rhexis margin. So you can have a fragmentation of the nucleus beyond the rhexis margin. So you have already a pre-chopped nucleus. You've got a rhexis there. So many times, in IFS, when you put the side port incision to do the rhexis, the iris will start coming out. The rhexis will, the pupil will becoming more floppy and becoming small as well. So I think all these problems are overcome by doing a flax. My cutoff is 5 millimeter, so that you can go for a 4.5. Anything less than that, I would straight away go in for any of the iris expansion devices, which Suvan beautifully explained.
The point I want to make, Mohan, was that
Not take any more points now. You're really running late. We go on to our next section, because you all have to be very concise in your answers.
No, just one concise point. I mean, in the sense that when you have a 5 millimeter pupil with the catalyst, it naturally has a 500 micron offset. So if you just use the instrument as such, you will end up getting a 4 millimeter rhexis. What I was trying to say is that you can use the
pupil maximize, you can do that.
And position it in such a way that it's just 100 microns away from the pupillary margin.
100 microns is a little too small, Ramu. 100 microns sometimes, I have done that as well, but a little too scary. Sometimes, there can be skip areas as well. So I always keep it at least about 300, 400 microns away from the pupil.
100 is also quite safe. We shall now go on to our next set of talks on hard cataract. And we have two young dynamic heroes, Dr. Shreyash Ramurthy, who's a consultant cataract, cornea and refractive services at the Eye Foundation Group of Hospitals, who's going to talk on my approach in Phaco with hard cataracts. And we have Dr. Shail Vasavda, who's again a consultant cataract, cornea and refractive services from Raghudeep Eye Hospital. And both of them, I'm sure, are going to stick to their 5 minutes and tell you senior guys that how 5 minutes is important too, and still get the information across. On to you. Two of you are challenged now.
Thank you so much, and good evening, everyone. So I think both Shail and I are comfortable with both Phaco and Flacs, but we have to highlight one point versus the other for the hard cataract, and my job today is to talk about Phaco. I think a lot of topics have already been, points have already been covered by the previous speakers. But today, one of the reasons why we go on to attempt Phaco in almost any kind of cataract is, I truly believe, is because of these two reasons. One, of course, repeatable chopping techniques that we have, good, whichever technique you're comfortable with, but making it repeatable is most important and allows you to approach any kind of cataract. And of course, having advanced Phaco machines which have excellent fluidics and excellent chamber stability, which I'll try to demonstrate in the next 2-3 videos. So I've selected 3 videos where I feel I would have definitely been better off doing a Phaco in these cases rather than Flacs. This is a patient with iris and a lens coloboma. Fortunately, the lens was quite stable, but in these cases, it's important to use sufficient pupillary expansion and ensure that you have good visibility, because there is a high chance that you may end up with some kind of complications, because these microcornea coloboma cataracts tend to be quite hard and the bag can also be quite weak. Most important in these cases is effective chopping, ensuring that the posterior hard plate is cracked. And once your hard plate is cracked, you can go about with the phacoemulsification. At any point of time during this case, if the bag or that potential point of weakness at the site of coloboma becomes weaker, it's important to insert a CTR and then go ahead with the procedure. Fortunately, in this case, the bag was quite stable and I was able to complete the phacoemulsification very effectively. Even in these very hard cataracts with the good fluidics that we have, we are able to restrict the amount of energy consumed in these cases and implant good advanced lenses in the most difficult and most challenging of situations. This is a patient who also had a significant 4.25 diopter cylinder, and I was able to give him an excellent outcome with a toric IOL implantation. Yet another patient with a black cataract. These are patients who originally, possibly many of us even today, today might be attempting to do a small incision cataract surgery, and I don't think there is anything wrong in doing that. But with any platform which you're using, the earlier video was with a Centurion, this one is with a Signature, any platform which you are comfortable with, once you've mastered the fluidics in that particular case, in that particular machine, you can go ahead even in these challenging situations, in these grade 4, grade 5 nuclear sclerosis also. So again, I would cannot overemphasize the importance of having an adequately sized rhexis, and then subsequently having a subsequent multi-quadrant hydroemulsification and ensuring that the hydro gives you a freely rotating nucleus. I try to do a slightly central trench, a deeper central trench, so that I can get a deep hold. And once I get a deep hold, I can then go ahead and chop the nucleus. Now, there is a higher tendency for the nucleus to rotate if your hold is not very deep, and this may cause splaying of the two pieces, and you'll have the posterior leathery fibers which are not detached. And very often, you may not get it in one chopping attempt, and you may have to do a multi-level chopping to ensure that the posterior sinews are completely detached, as you can see in this particular case. So again, do as many pieces as possible, as was already alluded to by the previous speakers. Could make it 8 pieces, 12 pieces. Even with manual chopping, you don't really require flax for that. And once you have completely chopped it and right up to the center, the pieces have been broken, then you can start your emulsification. You can see this, the black nature of the cataract, and even these kind of cataracts can be easily emulsified with the modern day Phaco machines with good fluidics. And even in the very last piece, you can see that the chamber is very, very stable. And this really allows you and gives you the confidence to go approach any of these cases with a Phaco emulsification, implant any kind of IOL. And this was a patient who wanted a toric multifocal IOL, and it is possible to promise them excellent outcomes even in very difficult situations. The final situation which I'm showing is a intumescent cataract with a dense cataract and also a small pupil. Again, my go-to technique in these is to make an initial small rhexis, and once the small rhexis has been made, you can then debulk the cortical matter, reduce it, and then go ahead and cut it with a micro scissor and enlarge the rhexis so that you have a sufficiently sized rhexis for a Phaco emulsification. None of these situations, the flax is going to give you any distinct advantage, and using the proper micro scissor and micro forceps along with your appropriate Phaco technique is what is going to be useful in all these situations with a dense cataract. I think what is more important than deciding whether you're doing Phaco or flax is really the technique, the comfort with which you're going to approach each of these cases. If we are comfortable doing a Phaco emulsification in a harder grade of cataract, the flax is not necessarily going to add any additional value in the overall outcome of the case. In flax itself, while in harder cataracts, the laser does penetrate only up to a certain depth, and especially in white cataracts, there is no penetration whatsoever. In these black and brown cataracts, it does penetrate, does make your chopping a little bit easier, but at the end of the day, the posterior fibers are still attached, and you still require a proper chopping technique to ensure the pieces are completely separated. It is not useful in smaller pupils, as was already discussed, and I think that's a distinct disadvantage of the flax platform. And yes, multiple papers have shown that it does reduce the overall Phaco energy. Now, while it does reduce the overall Phaco energy, in most of the videos which I already showed, there's hardly any time when I actually come out and repeatedly inject a viscoelastic. As long as the plane of Phaco emulsification is adequately posterior, and your chopping is good, and you've broken it down into multiple pieces and emulsifying comfortably with the kind of machines that we're using today, we are able to get a fairly pristine corneas even in these difficult situations on day one with a normal Phaco emulsification itself. So how much more is the flax going to add? What clinical or surgical significance is the flax going to provide apart from a numerical, statistically significant reduced Phaco energy is something that we all have to ask ourselves. Thank you so much for your kind attention.
Thanks a lot, Dr. Shell.
Very nice. Yes.
Very nice. Let's hear from you, Dr. Shell.
So we do receive research grant support from Alcon Laboratories, and I'll be talking about the LensX platform. So the first thing is that in a normal case, I would do a capsulorhexis of about 4.8 to 4.9 for a dense cataract or a black cataract. With the Flacs, I would do a capsulorhexis of 5 to 5.1 millimeters. So that's the first change that I make when I use Flacs. The second change, even for a manual phacoemulsification, and more so for Flacs, I would do a very minimal hydrodissection, particularly in a very bulky, large black, particularly in those black cataracts, where the capsule is also very fragile, and there is also some increase in the intralenticular pressure due to the gas bubbles. The third is out of the various division patterns that are available across different platforms, they are pretty much almost the same across all platforms. My preference is the chop pattern, because that's something that's how we have learned our phacoemulsification, and I think that works most efficiently. So this is a case to highlight that a sort of grade 4 kind of, not the typical black cataract, but brunescent cataract. And notice these air bubbles when they come out when you make one crack. So there will be some intralenticular gas bubbles that would have been accumulated, but typically during the first and the second crack, they tend to give out. The major advantage here is that because they are not, although they are not cut up to the base plate, because already 3/4 of the cut has been made, you require lesser lateral separation in many of these denser cataracts, which we would, in a normal phacoemulsification, you would probably require a little more lateral separation than would be required at this point of time. So that is one advantage, that because they've been pre-cut, the amount of stress that you may put to the zonules may be relatively lesser compared to a manual phacoemulsification. Like Dr. Himanshu Mehta sir showed, even in a small pupil, you can maintain the pupil size by maintaining your fluidics. That means low bottle height, low IOP, and low aspiration flow rate, and make sure that this pupil remains small. And because the pre-cracking of the nucleus has been done, I don't need to go very much below the iris to do a horizontal kind of chop, even in this dense cataract. So that is an advantage, that if the pupil is relatively small, but not so small that Flacs cannot be done. And my cutoff for the rhexis size would be 4.7. I wouldn't like to go anywhere less than 4.7 for a dense cataract with the Femto platform. This is to highlight again that even in an extremely dense cataract and with pterygium or an overlying opacity, because the cracks have been pre-cut, it makes life relatively easier. And I would like to highlight or emphasize that with most platforms, what you can do is 6 or 8 pieces. But for such a dense cataract, that may sometimes be inadequate. So after having done the 6 fragments that were already done by the Flacs, I go ahead and repeat or subdivide these 6 fragments again into smaller fragments. So that smaller or less, the smaller the fragments are, lesser will be the tumbling that occurs in the anterior chamber when you remove and emulsify these fragments, and therefore they will hit the endothelium less, and therefore you will have more clearer cornea. So after having the Flacs pre-treated divisions, I further go ahead and divide them even further into the smaller fragments up to about 10 to 12. And you can notice that once these are divided into such small fragments, then they are much, much easier to sort of emulsify inside the anterior chamber. I would like to also again emphasize that just because it's Flacs doesn't mean you forget all the other principles of dense cataract phacoemulsification, which means that you need to keep topping up the endothelium with dispersive viscoelastic from time to time, because that's something that will show up the next day on the slit lamp. And every 3 to 4 fragments, I would strongly urge everyone to top it up with a dispersive viscoelastic in this case, to make sure that it does, protect the endothelium. And with such a dense cataract, we are able to get a fairly low CDE, which would not be generally possible with the manual phacoemulsification. Just to highlight again an extreme case of an almost black cataract, and still you can see that the cracks, at least the tracks have been made, and the amount of lateral separation is far less than what would have been otherwise required, and I'm able to complete it in one crack. But there will be cases of the extreme black cataracts where your normal simple lateral separation will not work. And this is one such case where the Flacs has made the pre-tracks, but still the fibers are so leathery that you go inside again at a deeper plane and complete the division, what we described as multi-level chop a few years back. The concerns with FLAC, does these gas bubbles, do they cause any serious problem? They don't. And particularly now with the better understanding, we have increased our spot layer separations for lens fragmentation, which means we are delivering very little energy than what we used to do earlier. So I think FLACS is of great assistance. It's not a replacement. So both are complementary to each other. And that's my take home message, that we are not competing one technology with the other. We want to complement one technology to the other. It is not magic, and it will not work in the blackest of black cataracts, whatever technology that you may have. And you still need to follow the principles of dense cataract emulsification. Thank you so much.
Thank you so much. I'm going to just take one question from each of you before we go on to the next set. One question to Shreyas is, in case you have not been able to get your chops done in a younger surgeon, or if it's a dense cataract, what would you do next?
I think the first and foremost thing is, till you separate the posterior plate to the extent possible, to not proceed with the phacoemulsification. Yes, you may debulk a little bit to just increase the amount of space that you may have in the capsular bag in some of these larger cataracts. But if you have debulked a little bit of the center, there is sufficient space available in the bag. And it is important that you try and repeat your chops, maybe at different segments, till you crack the posterior plate. Because once you have done that, I think half the job is done. Yes, further breaking it into multiple pieces always helps. But if we try to proceed with the phacoemulsification without cracking the posterior plate, that is when we invariably land up in trouble, zonular issues, the bag getting damaged. All these problems happen only when we proceed with the phacoemulsification without chopping the posterior plate. Once that has been cracked, it is easy. Yes, with multi-level chopping, holding a little more posteriorly and attempting to reach up in the same area, you can ensure that it does happen. The lateral separation which Shail was referring to is a very important point. I think that's where it becomes even more important that we go even deeper, because most of the lateral separation is necessary to separate those posterior leathery fibers. And if you're holding a little more anteriorly, you would actually have to separate even more and more. It is just the way, the distance of where the fulcrum is from the point of effort. So, so going a little more posteriorly, holding it closer to the area where the attachment is, and then separating it, you will require lesser energy and lesser force of lateral separation to separate the pieces.
Dr. Shail, in these hard cataracts, you could have inadvertently done a lot of pneumodissection. How would you handle that? One small tip.
So I think one is, I generally don't hydrodissect such dense black cataracts because the pneumodissection typically works, and the first crack actually releases all the bubbles. And only if after the first crack, if I'm not able to rotate, will I come out, inject viscoelastic, and then do a gentle hydrodissection. I think that this is the most easiest thing to do.
Thank you so much. Both of you are really wonderful. Do stay connected. And
I wanted to ask a question to Dr. Shail.
Yes,
Doctor.
I wanted to ask you, since you were using Centurion and you were showing these hard cataracts, do you find any difference between the Kelman tip and the balance tip which they have to offer?
I think pros and cons, if we look at it, the balance tip, the pro is that it is more efficient for nucleus emulsification, which means we are needing at least 30% less energy than we would be required with the Kelman tip. The disadvantage is that because the balance tip has a slightly smaller internal diameter of 0.9 millimeters, the hold is, compared to a Kelman tip, the hold is relatively less. So it does get some getting used to in a dense cataract to, get that firm grip to crack the nucleus. So I think the advantage is that it's more efficient in removal. The slight disadvantage is the hold is less. But the drawback for the Kelman is that it gets clogged very quickly, particularly in a dense cataract, or if you are using, topping up repeatedly with dispersive viscoelastics.
Can I add one point, Chitra?
Yes.
No, I think the biggest, both the talks are very good, Shreyas and Shail, but the biggest advantage of flax in very brown cataracts is that you have a rhexis of a good size, like what Shail mentioned. Second thing is, you don't have to do much lateral separation. You need to, because already it's pre-chopped, and the very fact that the gas bubbles are coming, you can see the Shail's videos as well. Gas bubbles are coming out. it means that the cut has gone all the way to the posterior plate. Because in a manual phaco, then you need to go repeatedly. Every time you go repeatedly, you need to give phaco energy and cut and do lateral separation. Whereas it's already pre-chopped cataract in a flax, it makes the life easy because you go in and then do you don't have to even use a sharp chopper. You can just separate like that. So that is the advantage of flax, I think, which reduces the phaco energy. In our study, we have done that it's almost 1/3 of the phaco energy of what we use for a manual phaco.
Thank you very much. We have 4 more groups of talks. Mr. Sunil, please do inform about the time. And I would be very obliged if all the speakers stick to 4.5 minutes and not 5 minutes too. So we have the next set of talk, which is very good, on soft cataract. And we have 2 great surgeons talking. One is Dr. Debashish Datta, who's a senior consultant cataract and cornea services from Disha Eye Hospital, and a top-class surgeon. And I'm so confident he'll give us all the points we need to know about my approach in phaco with soft cataract. And talking on flax with soft cataract, my approach would be Dr. Rohit Om Prakash, who again heads the Om Prakash Eye Institute at Amritsar and is so very popular and famous for his superb education programs, which has been conducting. And we look forward to hearing from both of them. We start with Dr. Debashish.
Thank you, madam. Am I visible?
Yes, yes, yes.
Yes, thank you, madam, and the entire ARC and the expert panel for giving me this opportunity to discuss this soft cataracts with you. So, the cataract surgery being a refractive surgery these days, here I am doing a soft cataract with a steep axis phaco. I would I need to do some cylindrical corrections, so I am making a ledge and the inner eye sort of, and the parallel to the cornea to begin with, and then heel down into the cornea. This will give us a stable wound to begin with. Now, we practice aliquoting. 1 ml tuberculin syringe is filled with HPMC in bulk from behind, and cohesive viscoelastic is filled up in the anterior portion. So when we inject, so this is done before surgery for about 10 syringes we make. So it is the cohesive thing which comes out, and below the cohesive, the HPMC is delivered. And in the soft cataract these days, we know that the negative dysphotopsia is a difficult thing, and we don't know the exact cause of it. But these days, I'm trying to make a temporally oblong rhexis. This is another one in which I am putting a toric IOL, and the incision size is 2.2 for soft cataract, and the lateral exit should be larger. So here I'm trying the classical method of doing a trenching and then rotating it 180 degrees and completing the trench a little to the periphery. So in the soft cataract, this can also be done. So the power has to be low. Now doing it on the other side and then rotating it and doing it on the other side. So in the soft cataract also, if somebody is to begin with, now a blunt instrument, 2 blunt instruments will do. Any 2 blunt instruments will bring about this job. So in soft cataract also, we can do a 4-quadrant technique. So now it is the classical blunt chopper. Look at the CDE. I'm going to the periphery, and the tip does not move much. There's a oblique torque, but again it is placed and the separation is done manually mostly. So it is the horizontal chop being executed from the periphery to the center of the phaco tip. The phaco tip just holds it by some amount of power and holds it mainly by vacuum. That's how it goes. So classical blunt chopping is possible, horizontal chopping. Here, the rhexis has been done and the fluid wave hydrodissection is being done one way, and the other side, a little bit of more hydrodissection will prolapse the one pole of the nucleus into the pupillary plane and anteriorly. And with the higher vacuum and some amount of power, this soft nuclei can be emulsified in bulk. and you can take help of the second instrument, but somehow I find it this extremely nice. It's Phaco machines does not require a second instrument to be used. Now here RIX is being completed, and the Utrata forceps, if you are stuck with Utrata forceps, these are type of Rexis forceps can be used with the small incision sizes. Here I'm trying hydrodelamination has been done, one golden ring and another golden ring. So this makes things quite simpler. So I go forward, this can be emulsified. This makes things easier. So the entire thing, along with the epinucleus, first the nuclear central portion and along with the epinucleus, can be emulsified easily. The remaining portion needs to be positioned opposite to your incision and then taken away and eaten away. So here is a mixture of horizontal and vertical chopping, a mixed chop. This is what I practice usually. So it's a sharp chopper being used. So a sharp chopper can also be used. This is not always a cheese wearing, but a mild hold and a gentle mixture of horizontal and vertical chopping makes things simpler. So then it is an easy way to remove the thing. For a beginner, it is for a resident doing it. So he makes a deep trench, and instead of stop and chop, one can do a stop and he's breaking it some type of pre-chopper and stop and emulsify. The heminuclei can be emulsified in toto. So because they're soft, we don't need to divide and conquer and stop and chop. So chopping is not required. So the entire two heminuclei can be removed like that. So, on a posterior polar cataract, so a little bit of aliquots are given. The fluid wave should not reach the posterior pole. The hydrodelamination is being done, and a sharp chopper is being used to make a wedge. Sorry for the video quality. This video quality is not very good. So first a wedge is removed. Now the nucleus being free. Multiple chops are being done, and they can be removed just like that. The epinuclear sheet is also removed by aspiration, simple aspiration. Here I'm trying to do a carousel technique. I'm not very confident. This is Dr. Om Prakash will be enlightening us on this. I think he does it very nicely. So here I'm trying the carousel technique, but I'm not able to complete. So I'm using it, holding it with vacuum and removing it en masse. So it is a mixture of various techniques that one has to follow to as and when required basis. We will be able to manage the soft cataracts. Thank you so much. Hello.
Dr. Sinha, you can take forward, ma'am.
Chitra ma'am gone off. Thank you so much, Dr. Devashish, for that wonderful presentation. We'll now move on to the next presentation by Dr. Rohit Om Prakash, who will be speaking on ultra soft cataracts.
Hello, can you hear me?
Yes.
Yes, sir. Yes, sir.
So I would like to thank Dr. Chitra for this opportunity to speak in this ARC webinar. And I would like to congratulate Dr. Devashish for making things so easy for me. So I would be taking... So we have to realize, can you hear me? Hello?
Sir, you're audible, sir.
Yes, sir, we can hear you, sir.
Yeah.
Yes,
So
Rohit.
I would be talking about ultra soft cataract, the surgical norm. Hello. So there is an increasing soft cataract surgery number, and there are a variety of reasons behind it. What is really an ultra soft cataract? That cataract which doesn't have any nuclear sclerosis, and the patient is in the age group of less than 50 years. In these ultra soft cataracts, there is difficult fragmentation and difficult holding. And why do people in older age groups do not have a truly soft cataract? Because the nuclear mass is firmer and it is unmoldable. So this is a video wherein the holding is difficult. And when you're trying to, fragment it, it cheese wires. And when you hold it, you end up in emulsifying it. So there is difficulty in holding and fragmentation in these ultra soft cataracts. So let's see this video in which Flacs assisted cataract surgery would be done in this ultra soft cataracts. My technique is to create capsulorhexis at the, hydrodissection at different places. And after partial fragmentation has been achieved, because in these patients, you find it difficult to rotate also. So once, partial fragmentation is there, then you can continue and complete the phacoemulsification. This is courtesy Dr. Chitra, wherein you will find that the cataract is ultra soft. Here you can do, in these cataracts, the fragmentation has been achieved. And when in these patients, fragmentation has been achieved partially, then, with visco and with hydrodissection and with manual separation, you can achieve some amount of, emulsification of these partially fragmented nuclear fragments. But there are situations where nothing is possible, where you cannot fragment because the cataract is overly soft. In those patients, as Dr. Debashish also said, my preferred technique is doing the 2-in-1. I use the capsulorhexis to my advantage, try to partially fragment it, but I use the, the rapid technique for en masse soft cataract phacoemulsification. This technique was there as the top 5 articles, top 5 techniques, rather the top technique in AIOS. Now, what happens in this technique is, the first is the R part of the rapid technique. You should be able to rotate it. Once free rotation is done, then you have to align the phaco tip and place it at the nuclear rim. Just see the CDE. CDE is going to be is 0, and you will find in a jiffy you have been able to emulsify the soft cataracts. This I do in cohesion with Flacs also, where fragmentation is not possible. This is another video. The first step is, you have to rotate it. Try clockwise, anti-clockwise. Once you are able to do that, then aligning of the phaco tip, then placing the phaco tip at the right place, and then impaling it. And once you impale it, then you can use the devouring of the nuclear fragment. The CDE is 0 in this patient. So this is another video wherein you will find another important factor which is involved is that the capsulorhexis has to be adequately sized in these non-moldable ultra soft cataracts. Hydrodissection at multiple points, so that you should be able to rotate it freely. Once you are able to rotate it, then you have to align it and place it at the nuclear rim, impale it, and then devour it. So these are the steps in a patient with ultra soft cataracts, wherein you can use both the Flacs and the rapid technique to your advantage. So my technique for ultra soft cataract would be partial fragmentation with Flacs, hydro-visco separation as was shown. And if you can still not separate it because it is ultra soft, then you can use the rapid technique. Thank you very much for your kind attention.
Thank you so much, sir, for that wonderful presentation. Yes, sir, Dr. Ramamurthy, sir.
I think excellent videos. I mean, the one point we have to understand is when we talk about truly soft cataracts, they are the cataracts which do not have a formed nucleus. Really, chopping is not an option in those cases, as was shown by Dr. Rohit. Dr. Debashish also showed excellent videos, but to my mind, if chopping is possible, it's truly not a soft cataract. And in these cases, making a 5.5 millimeter rexus, whether do it with a femto laser or whether you do it manually, and then doing a good hydrodissection. Unless there is a posterior polar cataract, I would not do a hydrodelineation. Actually, that just increases the amount of work you have to do because the nucleus comes out separately. Then you have to go after the cortical matter separately. So once you hydrodissect it, then the whole thing stands up or prolapses into the anterior chamber, and you can just go ahead and either do it in a very elegant way, the way Rohit showed, a carousel technique, or just do a phaco aspiration using zero phaco power. And in case you are using a laser with that, as again Rohit showed, we do not use any fragmentation or anything, just use a sextant. And instead of doing the hydrodissection through the in the rexus margin, we actually go through the central chop, either do a visco or even a hydrodissection, and the fluid wave just goes all around and tends to come out through the chops that you have created. So that at the end of the hydrodissection, you almost have distinctly cleaved segments that are there. And you can, once you have removed the cortex, which is overlying cortex, you can just go ahead and pick them up one by one in a very elegant way, and the whole job is done. I think at the same time, we should not underestimate these cataracts. Because of the softness of the cataract, there is greater chance of cheese wiring, damage to the posterior capsule, etc. So using the right parameters, as the two speakers showed, you are able to conquer most of these cataracts using, I think most of the job is done in phaco aspiration. There's hardly any power that's needed.
One suggestion would be that if you're using the flax, I think instead of trying to do the chop pattern, maybe doing a cylindrical pattern or something may be more easier.
Lensex, you can do that, no?
Correct. Yeah.
Absolutely.
Can I just make a quick comment, Chitra?
No, Dr. Mohan.
No,
We are a set of speakers. We can't do that. We shall go on to our RNI discussion. Should also be kept very brief. We go on to our next set of talks on subluxated cataract, phaco versus Flacs. And we have, again, two top guys talking. Of course, I don't see Dr. Kamal, but we will take Dr. Kumar to talk on my approach in Flacs. And we all know Dr. Kumar is the CEO of the Doctor Eye Institute, Mumbai, and is again a very prolific surgeon. And he's definitely going to tell us all that we need to know about managing a subluxated cataract with Flacs and why we would do it that way. On to you, Dr. Kumar. Mr. Sunil, could you check on Dr. Kamal Kapoor? Yes, while Kumar is sharing his presentation, Dr. Mohan, can you take that discussion point of yours?
No. Thank you very much, Chitra. And really, both the presentation very good. Only thing
So
is,
I'm going to talk. Thank you, Chitra, for this opportunity.
Kumar.
Yes.
Give me 30 seconds. No, the biggest problem is the NHNT, neither here nor there cataracts. And my complete go-to technology will be Flacs for this NHNT cataracts. That's one message I want to give you.
Yeah. Thank you very
much. These cataracts don't chop, don't suck, don't crack. Yeah.
Yes, Dr. Kumar.
Okay, Kumar. Thanks. Kumar is stuck. Kumar?
Dr. Kumar, maybe you could...
yes.
I hope we didn't hear 30 minutes.
Can you hear me? No, I said 40 seconds. Thank you, Dr.
Yeah. Your network is not so good like mine. Kumar, maybe you could change your network to phone or your iPad. I think
he's freezing there.
Yeah, I think we would go on to the next set of speakers. We have Dr. Kumar, your network is not good. We can't hear you.
So now you can hear me?
Now we can hear you. Yes. Yes.
No.
No, we don't hear you. Mr. Sunil, can you talk to Dr. Kumar to change his network to phone or iPad? We go on to the next speakers. Please call him right away. I'm sorry. And we go on to our next set of interesting topic. which is on low diopter astigmatism. And this is going to be dealt by, again, two experts in cataract.
Back. And I'm trying to adjust the rexis as well as that. So all this is done quite easily.
Not able to see, ma. Not able to see your slides.
You're not able to see your slides, Kumar. You change your neck back till I go with the next set of speakers. We want to hear you definitely.
Dr. Kumar, your video is freezing. You need to change the internet connection.
You need to change the connection. And in the interim, I'll just go with the next set of speakers and we will come back to you, please. Sorry about that, Dr. Kumar. So we go on to our next set on Dr. Sandeep Nagwekar, who's again a very leading practitioner from Mumbai and associated with Lilavati Hospital and his own private practice. And he is going to give his viewpoint on how he would address low diopter astigmatism by Phaco technique. And talking against him would be Dr. Arulmozhi Varman, who is again one of the pioneers of phaco emulsification in our country. And he is the driving force of his Uma Eye Clinic based at Chennai. And he is going to talk on how he would approach Flacs for this particular astigmatism. On to you, Dr. Sandeep.
Thank you, ARC, and thank you, Chitra, for inviting me for this lovely webinar that's going on. Just to disclose, there's no interest in any of the products or technologies mentioned in this presentation. Now, you can see from this slide that after spherical errors, astigmatism remains the major cause of reduced uncorrected visual acuity. Even at a level of 615, 612, the quality and quantum of vision drop. And hence, it's very important to, at least in this modern world, when we are talking in terms of refractive cataract surgery, we need to address these low diopters of astigmatism. So what are the treatment options for this? You could leave it out and ask the patient to wear glasses or contact lenses. Not a very great idea because it's highly patient dependent, it's a lifestyle problem and there's always a recurring expense on all these. And of course, you can do incisions like LRIs, OCCIs, and opposite paired incisions. And excimer laser is, I'm going to talk about that in a little while. Excimer laser not a great option because it's a separate procedure by itself. And along with that comes its own complications of flaps and glare and halos at night. But what really stands out, in my opinion, in today's day and age to correct low diopters of astigmatism is the toric IOL, which is accurate, consistent, and a predictable way of treating astigmatism. What are the drawbacks of the limbal relaxing incisions and arcuate keratotomies? Is that they leave behind a foreign body sensation in the immediate post-op period. They lack precision, they are inconsistent and therefore unpredictable. They commonly regress over a period of time. And in case of femto LRIs, at least at this point of time, there's no standardized nomogram available for the calculation of the arc length and the diameter. The advantages of a toric IOL, on the other hand, the correction achieved is consistent and reproducible. The correction is permanent. And depending upon the age of the patient and the amount of astigmatism, it is possible to modify the residual astigmatism favorably to counter possible future changes. And there's very minimal or no rotation with modern hydrophobic IOLs. As you can see, this is a picture of an IOL taken just 1 week post-operative, and the same IOL seen 27 months post-op. There is no rotation at all. So amongst the various options which are available for correction of low diopter astigmatism, toric IOLs seem to be the most promising. Now, how do you fine-tune the choice of the low toric? You have to calculate the anticipated post-operative residual astigmatism, and this can influence your choice of the IOL. So in case of a monofocal IOL, it may be desirable to leave a small amount of against the rule astigmatism because that improves the depth of the focus. Whereas in cases of multifocal IOLs or when you are going to implant an EDOF toric IOL, achieve complete emetropia or leaving behind a mild residual with the rule astigmatism actually helps the patient and it can counter any possible drift with age. Now, how do I plan? I divide astigmatism from 0 to 1.25 as low diopter astigmatism. And if you look at it as with the rule and against the rule, for 0 to 0.3 diopters, I stick to a temporal 2.2 millimeter incision and I implant a non-toric lens. For a 0.3 to 0.7 diopter incision, I stick again to a temporal 2.2 millimeter incision. I might put in a non-toric or I may make a small limbal relaxing incision. In cases of 0.7 to 1.25 diopter, if I want to neutralize the astigmatism, I make a superior 2.75 millimeter incision and put in a non-toric lens. or if I'm going to put in a multifocal or a presbyopia correcting lens, then in that case, I'll go in for a 2.2 and calculate my astigmatism in that manner. As far as against the rule astigmatism is concerned, in cases of 0 to 0.3, I make a temporal 2.75 millimeter incision to neutralize whatever astigmatism I can put in. I put in a monotoric, I mean a mono non-toric. I may or may not add an LRI to it. And if I'm going to address it in cases of presbyopia correcting lenses, I will go in for a temporal 2.2 millimeter incision and implant the appropriate lens. For a 0.3 to 0.7 millimeters, it is always going to be a temporal 2.2 millimeter with a toric lens, and also for a 0.7 to 1.25, whether it's going to be a monotoric or a presbyopia correcting IOL, I'm going to go for a temporal 2.2 because my SIA for this particular incision is just 0.1. So what is my approach in Phaco? I mean, there are so many things, and Chitra, you asked me to cut down on time. So the most important thing is to identify the major and minor axes of the astigmatism, use an optical biometer as far as possible. Once again, confirm the major axes by using a corneal topographer. Use any system of marking. You can use markings, or you can go for digital guided systems as we are doing today. It's very important that you do a careful phacoemulsification, implant the lens, and align its steep axis with the steep axis of the anticipated postoperative residual astigmatism. Don't forget to remove the viscoelastic from behind the lens. And in cases, as I said, for hydrophobic lenses, the lens, once you put there, it stays where it is. Phaco versus Flacs, there's no particular advantage of one technology over the other, at least as far as this topic is concerned. I mean, every other cataract, whether it's a hard cataract, a subluxated cataract, a soft cataract or whatever, Flacs may have some advantage. But as my worthy friend who's going to follow me will tell you, that the biggest difference between these two procedures is the cost. The toric IOL is an inexpensive way to mount the bridge between using a Flacs for doing an LRI. Even a multifocal or a more expensive of toric IOL does not cost anywhere more than 2,000 to 3,000 to about 9,000 more than a non-toric IOL. And the best LRIs are actually delivered either with a diamond knife or a femto laser, both of which are very, very expensive. And I don't need to remind my dear friend who's going to follow me what he paid for both. So if you ask me, if you take a Phaco and a toric IOL, according to me, it's the best way to manage a low diopter astigmatism. There are no major investments required to implement this technology in our practice. And you can do a concomitant treatment of cataract and astigmatism using one single safe and dependable technology. Thank you very much.
Thank you very much, Dr. Sandeep. That was a very crisp talk. Let's hear from Dr. Arul Muyvarman before we go to a brief discussion. Dr. Arul, are you there? He's connected, yes. Dr. Arul, you need to unmute yourself.
Thank you, Chitra, for this opportunity. I'm going to talk about low diopter. It's very, very clear as to what the talk is about. We are now discussing low diopter astigmatism. There are two ways I can look at it. How do I handle low diopter astigmatism in a patient who's already committed to getting Flacs done? Or would I take Flacs as the go-to technology in a person who's going to go in for a low diopter astigmatism? So what would you consider as a low diopter astigmatism? Oh, this is hanging. 1 minute.
Hi, Arul.
Hi. I have to go back to screen sharing, and why is it hanging? Okay, share. Okay, can you hear me now?
Yeah.
Yes. So why do we correct astigmatism? It interferes with visual outcomes, and particularly the advanced IOLs such as multifocal and EDOF IOLs. We can handle it by incision placements, which I really don't think it's a very good way to go about it, because it's going to make a big difference as to where you make the incision and how you make it and how the results come about. LRIs and toric IOLs would be the way to go for low astigmatism. In astigmatism over 2, toric IOLs definitely score over everything else. So let's look at this. What do you want to get out of getting this accuracy? You first need to get a perfect CCC. And nowhere can you get a perfect CCC as you would get in Flacs. It is going to be centered on the capsular bag when you want it to be, and that's where the lens is going to sit. 2, accurate marking of the axis of placement of the toric IOL. If you want to do it, Flacs can do it for you. And laser LRI is absolutely accurate with the Flacs. So what is low diopter astigmatism? Anything less than 1.5. Anything above 2, I would go in for a toric IOL. So what are the choices we have? We can still put in a toric IOL in low astigmatism, or you can do a laser LRI. So Flacs can be made to use. How is it going to help? You can make it alignment marks on the cornea as it comes, as available on the Catalyst machine, or you can make it on the capsule if you have the LenSR, both of which give you excellent accuracy. So I have a quick video here where I'm putting in his lens. I'm comparing it. I'll just go to the end of the video for time. You can see here, this line that you've seen drawn very clear on the cornea was drawn by the Flacs machine. So this will help you to get accurate placement of the lens. And this has been cross-checked by me using the Callisto also, and it was found to be equally accurate. So this is one way to go in lower diopter astigmatism. If you wish to go in, you can go with the LRI, with the placement marking using the Flacs itself. The better way to go, because in low astigmatisms, there are enough number of studies that show you that LRI done with the laser is as accurate as putting in a toric IOL. I agree that toric IOLs are the ones that are going to be very, very accurate. As to lack of nomogram for this, I don't think that is necessary at all. I simply follow the nomogram that's available on the iTrace. I copy and paste. The new upgraded software on my Catalyst has got its own software and nomogram, which I've not started to use yet. I'm quite happy with what I get off the iTrace. I copy it, it tells me the arc, the depth, and it tells me the length also, and the placement, position, everything. So we have no issues with this, and we get excellent results. So you'll find that the end of the capsular excess and softening of the nucleus, this marking is the arc of a single incision for a low diopter astigmatism, as was suggested by the toric calculator on my iTrace software. What do I do in this situation? I use the algorithm from iTrace, depth as per iTrace toric planner. I use a penetrating one. Well, the Catalyst can give you intra stromal incision or a penetrating incision. So I use a penetrating incision. End of the surgery, I also open up the epithelium at the end of the surgery. So that gives me the better results. Studies have shown that in low diopter astigmatism, LRI done with a femto laser is as accurate as one done with a toric IOL correction. So no doubt about this. And another advantage is if you have gone wrong or you placed a normal lens instead of a toric lens in a patient for some reason, and the patient is unhappy, you don't have to go and take out the lens and replace it with a toric. You can still do an laser LRI after the surgery has been done. So my choice for low astigmatism is laser LRI. That's the best choice. It's accurate, it's proven, and no extra cost, particularly a patient who has already been committed to Flacs surgery. Thank you.
Thank you very much.
Exactly 4 or 5 minutes.
Yes, yes, wonderful, wonderful. Both of you did a great job and very clearly covered what we needed. Dr. Mohan, I'm going to ask you this question. If it is going to be, if your arcuate incision is going to fall on the axis of the incision, how would you proceed?
If the arcuate incision doesn't matter at all. Doesn't matter at all, because your arcuate incision is going to be slightly inside. It's in the 5 or 6 millimeter zone, and your incision is going to be far away from at the limbus. So that's not going to matter at all. And my cutoff is about 1 to 1.25, and not like I think Arul is going up to 1.5. 1 to 1 up to 1 diopter. I do the astigmatic keratotomy on the Flacs, and works very well. Fantastic results.
Ram, would you do a single incision or would you do a paired incision if the incision arc is going to come over like the incision side axis?
I think Mohan already clarified that, because our arcuates at 8 millimeter diameter, and most often we deal with against the rule astigmatism. I still stick to my temporal clear corneal incision and do a biarcuate keratotomy. And just a small comment, when we talk about low astigmatism, we need to clarify whether we are talking about with the rule or against the rule. Even the nomograms, and whether it's for intraocular, toric intraocular lenses, or even for the arcuate keratotomies, with the rule astigmatism, you find that even up to 0.5, 0.75 diopters, very often no toric intraocular lens is indicated. But against the rule astigmatism, it's a toric intraocular lens which is indicated. And even the arc length of the incision that you create in case you're doing a laser arcuate keratotomy will change depending upon whether it's with the rule or against the rule. So now our tendency is to straight away go ahead and use the Barrett toric calculator and feed the data into that, and let the formula tell us whether we need to go for a toric intraocular lens or a non-toric lens.
Okay. Dr. Sandeep, you would want to say just one line? You can give an answer.
Just one line regarding that question you asked regarding if the arcuate keratotomy comes in the way of the incision.
Yes.
And my laser platform is the LensX, which does not allow that unless there is a 30-degree separation. You must remember it's not 6 or 6.5, but 8 millimeters. So it can come quite close. And I would rather shift the incision, which is possible, rather than change the LRI. And you can do it dynamically.
I would rather make the incision with a diamond knife for a.
Correct. Yes.
So, yeah.
You can change the incision, side of the incision as well.
Yeah. Dr. Kumar, are you there? Dr. Kumar is not there. He was there till a minute back. Dr. Kumar? He's not there.
I'll call him, ma'am. I'll call him.
Yeah. We go on to
next talk, Chitra.
Last set of speakers, which is going to be on polar cataract. We have Dr. Naren Shetty, and we would have a recorded version of talk of Dr. Gaurav. Dr. Naren Shetty, again, is the vice chairman of the Narayan Netralaya group of hospitals and head of cataract and refractive service.
Sir, you're joining, sir. Okay.
And he is going to talk about polar cataract, Phaco, and polar cataract, and he's the director of the Dr. Naren.
Thank you so much, Chitra ma'am, and ARC for giving me this opportunity. Today, I'm going to talk about posterior polar cataract management. And in terms of doing Phaco in PPC, there are two ways. One is the regular Phaco, and then we have femto-assisted Phaco. I'll be talking about the regular Phaco. How do I handle it, and what are the tips and tricks of handling with doing a regular Phaco? One of the dreaded complications of PPC, handling a PPC, is a PCR or a posterior capsular rent. But how do we prevent it? I know we shouldn't blame our machines or tools, but the machine plays a very, very vital role in this situation, the machine and its parameters. So what is very crucial is, we should create as stable chamber as possible. So how do we create a stable chamber is to have the right parameters. Whenever we say that, okay, handling posterior polar cataract, we just reduce the IOP and do not reduce the flow and this one. So it is extremely important to change both. The other thing is looking at signs. One of the key things is preoperative itself. If we have an intraoperative OCT or an anti-chamber OCT, it is good to visualize the posterior capsule and see the integrity of it. That way you can actually grade it and also realize the rate of the chances of the PCR happening in these cases. So that way it's much better. You can counsel the patients, make them to understand. Also, you're also much better prepared. One of the very important crucial steps of handling PPC is the rhexis. You should have a nice, good round rhexis. Usually I create a little more smaller rhexis than normal, so that if there's a PCR, I can always do place 3-piece IOL in the sulcus and do an optic capture. Now, the other thing is, please do not do a hydrodissection. And when you hydrodelineate, do not forget to release the fluid which is gone behind. This is very, very important. We always release this only in a hydrodissection, not in a hydrodelineation. Always release it. That reduces the intradenticular pressure. So in these kind of scenarios, see, when already the capsule is already so weak, and you're planning to do a femto, then as you know, there's a more chances of the gas bubble upgrade. And even in a regular cataract, there's a chance of a PCR happening just because of these interlenticular pressure increased because of the gas bubbles, and if it's not left over. Now, in terms of chopping, we can, I mean, I usually follow, I split the cataract into two halves. And then once I've done that, I prolapse partially one of the halves into the anterior chamber. Once that is done, I take out my second hand piece and then complete the phaco with this. Once one half is done, I just snugly, I mean, just push the second half slightly anterior towards the center and then remove the second half. So moving forward, the one more way is where, let's say if you've removed one half, you can still rotate the nucleus. Do not be afraid. You can do a rotation of the nucleus, provided the delineation is good. As you can see, there wasn't any rotation of the nucleus or the cortex when I rotated. So once you've done that, you can again chop it, sub-chop it, and then eat up the pieces. Now, if for whatever reason that the nucleus does not rotate, what you can do is without rotating, just change your angle of your phaco, and then you can do again a small chop of a small nucleus. Once you chop it, then once you release or remove one of these small pieces, automatically the rest of the piece becomes more free to handle, and then you can remove all the pieces one by one. Now, let's say if it is a very soft cataract, you can, with the high vacuum and flow, you can do more of a zigzag movement and then prolapse the whole nucleus. I don't know why it's pausing, but anyway. So yeah, now you can visualize it very clearly. So it's hardly like a few seconds. You can just remove the whole nucleus, one shot. Now, in terms of removing the epinucleus, provided the PC is intact, you can just put the bevel down, and then if you go to the edge of the epinucleus, automatically the whole piece comes as a whole. One more way of controlled way of doing it is, pushing in a viscoelastic in between the two layers that will slowly separate the different layers. When you are polishing the bag, please remember, do not contact any of your instruments with the posterior capsule, because especially where the plaque was there, just use your fluid from the irrigation port and then wash the posterior capsule. I usually implant it in irrigation in these cases also. If you're not comfortable doing this, I would highly recommend you to use a visco and then implant the lens. The key to implanting this is whenever you push the lens, the first place where the IOL comes in contact should be beyond where the PPC was there. So because the place where the PPC was there, the capsule is very weak. So there shouldn't be any stress on those parts. Once you're done with your case, always hydrate before you remove your irrigation port. Hydrate the wounds without removing, so that there's no sudden drop in fluctuation in the chamber. This itself can lead to a PCR. Let's say if you do have a PCR and you have a little bit of cortex, whenever you're removing the cortical matters, pull it towards the central slit. That way, it will still remain, the integrity of the slit will be just like that. What if you have two pieces like this and you have a PCR? What you can do is you can push the pieces to the side, and then you can place a 3-piece IOL in the sulcus. Once you place it, then you can do your phaco using the IOL as the scaffolding. And once you're done that, please do not forget to do an optic capture. Usually do an optic capture perpendicular to the slit. That way the posterior capsule doesn't get captured when you're trying to tuck it in. And obviously, if you do have a nucleus drop, if you're not a vitreoretinal surgeon, please do not try to fish it out. Just leave it, just refer to a vitreoretinal surgeon and let they do the job. I'd like to end by saying, whenever you do have a posterior polar cataract, please do not panic. It's good to be very well prepared for that particular situation. Really assess it, counsel the patient, and make sure you have a set of steps and follow the same. Thank you for your time.
Thank you very much, Dr. Naren. That was a wonderful talk. Mr. Sunil, we would first take Dr. Kumar's talk to have the discussion. And unless Dr. Gaurav is there.
I'm already here, ma'am. I'm waiting actually. So can you do my talk first?
Yes, your talk. Yes.
Because I'll have to leave after 5 minutes.
Oh, Kumar, sorry, Kumar. We'll take your talk after this.
I'm out.
Yes. Yes, Kumar. You could play Dr. Gaurav.
Very good evening. Apologize for having to record this presentation and send it as I was traveling. And thanks to Dr. Chitra and the whole of the ARC team for inviting me to present here today. I'll be making my case for femto-assisted cataract surgery as the preferred choice for posterior polar cataracts in my practice. Here, just wanted to share with you one of my cases which started off as a routine case, and I used all the maneuvers. It is a non-femto-assisted surgery, did a hydrodelineation, cracked the endonucleus, removed it without rotation, did everything right. And in the end, when time came to remove the final chunks of the cortex, and this is where I had reached. I had aspirated most of the stuff from the peripheral equator. And at this point, when I was also doing the right thing by putting viscoelastic in, and now I'm with my bimanual IA, trying to get the final chunks out, thinking that the surgery is already over. And that's when those flimsy connections and, you will suddenly get a break. So there I have a big break there. So it's never over till it's over. And also sometimes you may encounter situations like this where there may be a pre-existing posterior capsular break. So what can we do? Over the years, I've been working hard to find strategies to tackle these cataracts. And I now feel that doing posterior polar cataracts requires multiple strategies. So the challenges are predictable rhexis size and shape and centration is very important, because if you have to do an optic capture of the IOL, you need a perfectly sized, right-sized rhexis rim, which should be well-centered and round. The big no-nos for posterior polar cataracts: no hydrodissection, no nucleus rotation, no cracking maneuvers as far as possible. Vigorous cracking maneuvers are bad. Lateral separation can always cause problems. And then once you are removed or done with the cataract, then the epinucleus management should be done well. And then the cortical aspiration done so well that you are left with only that last chunk. And I'll show you how you can remove that. And then, of course, it's not over till you have implanted the lens. Even at that stage, you can get a break in the posterior capsule. So let's see how I manage this particular case. So I use the catalyst laser, and here we've done the OCT scan, and you can see over here that there is this big chunk sitting there. So what we are going to do is to change the posterior cleavage plane from 500 microns. We'll change the offset to about 700 microns, as you can see over here. And once that is done, we are now in a better situation. So you can see over there that now my posterior laser firing will not happen in the posterior 700 microns, leaving the posterior part of the posterior polar area intact. And the pneumodissection also will help at this point, so that I don't have to do any hydrodissection. So once that is over, you go with your viscoelastic, make sure that your chamber is always stable. The rhexis is already done, as I said. It's almost a perfect rhexis, as perfect as you can get, perfectly centered, perfectly sized, and no hydro maneuvers. I'm going to just do a lateral separation, and for this the femto really helps, because the number of manipulations required are minimized for the nucleus. I don't have to rotate, I don't have to do any lateral separation, any significant lateral separation. The cleavage planes are already there. So the forces inside the bag are minimized. So I feel that this is the least invasive way that you can tackle a cataract in such a situation where your PC may be suspect, your posterior polar area needs to be left alone till the end of the surgery, and there could be nothing better than to have pre-cleaved nucleus. And you can see I'm only mobilizing it, and as you keep watching, I will continue to mobilize these chunks. I'm not going to do any separation, any rotation. I'm not going to make any other maneuvers. So you can see I'm just kind of easing them out, because the laser has already created my 6 pies, pizza pies. Now once that is done, I'm mobilizing another chunk here, and you can see the posterior polar cataract peeping through from behind those chunks, and that area has been left totally undisturbed by any of our maneuvers. So just easing these chunks out takes very little effort and very little disturbance of the internal milieu of the eye. And once we are done with that, you've now left with the posterior polar part. Inject viscoelastic before switching off the infusion. Here we have the advantage of the AIOS OCT on the microscope that we use now, the Artivo system, and we can quickly check whether there is a posterior capsular break. You can see that chunk there, and nicely it looks like the PC seems to be intact, but there are strong adhesions, as you can see on the right side. Now I'm starting with the process of aspirating from the equatorial bag and kind of ensuring that I leave only that last chunk attached right till the end. So I'm debulking everything from the peripheral cortex in the equator of the bag. Very gently, very stable chamber. No rotation even at this point. No vigorous aspiration maneuvers to aspirate that area which is stuck to the posterior capsule. That can just tear the PC, and I want to keep it right till the end just in case it breaks. Now I'm going to do a visco separation. So I go inside from the main board, inject viscoelastic to lift up this edge. This is the easiest and safest way to get the separation done. So you can do a flotation, visco flotation. I'm doing it from the second side. And now I'm fairly confident that it's become free. I use a plain manipulator. I'm still not going to aspirate it because aspiration is the key to having problems. I just squeeze it and make sure that the gentle separation, my posterior polar area is detached from the posterior capsule. And once that is done, now my game is 90% done. Quickly remove and aspirate that as it's free of the posterior capsule. And then comes the time for implanting the IOL, which again has to be done gently. The haptics should not touch the area of the PC where the posterior polar cataract is there. And once you've injected a hydrophobic lens into the bag, you can center it. Again, you can check the OCT. Just see on the right side, you can see the IOL nicely sitting and the PC absolutely intact there. The MIOCT has become a really useful tool in our practice to check such patients. So to conclude, I would like to say that there are several advantages to laser cataract surgery in posterior polar cataracts. It gives you a perfect predictable rhexis, which is an absolute must in posterior polar cataract surgery. It allows you pneumodissection, so you don't have to do any hydro maneuvers, which gives you an added level of safety. Pre-chopping is already done for the nucleus, especially in the harder nuclei, where this becomes a big blessing. No rotation is needed, so you can just remove those chunks as I showed you in my video. No lateral separation forces are required. The epinucleus shell can be managed in a much, much better way in such cases. And the nucleus removal is already complete before reaching the area of the PPC, so that in case you have a PC rent, the management becomes much easier. And the percentage of success, I think, is much, much higher when you're using a femto. It's much more predictable and controlled, and the complication rates are much lower. So I think there is no reason why we should not be actually doing the procedures with the femto assisted if you have the option. With that, I would like to thank everyone for allowing me to present today.
Thank you. Thank you.
Thank you,
Gaurav.
ma'am,
That was
for
a-
allowing me to present like this because I was actually traveling. So I'll be happy to answer any question if there is any.
Wonderful presentation, Gaurav. Very good.
Thank you, Mohan sir. Thank you so much.
And very sorry, Kumar, that we're keeping you. Just one question in this talk, although you two guys can really take a lot of questions. Supposing you have done on Flacs, you promised a multifocal IOL or a toric IOL, and you have a PCR. What is your take on doing a reverse optic capture of a single piece lens in these cases? Dr. Ramurthy?
Yeah, it's possible because in these posterior polar cataracts, yes, you do everything possible to avoid a REN, but sometimes it's inevitable and it happens. But one thing is that this is usually one pole to pole. It's it extends. It's not a central opening or something. It extends from one clock hour to the opposite clock hour. It's horizontal and there's no question of extension. In these cases, it's possible usually if right opposite to your incision, that is temporal incision, temporally and nasally, if there is enough capsular support that is available, then you can even go ahead and very gently implant the single piece intraocular lens in the capsular support that is available. And to support this, as was shown, if you have a 4.5 millimeter rhexis, you can just bring the optics alone into the in front of the rhexis margin so as to create a reverse optic capture. And it does work. It's not the best of solutions, but obviously with the second eye of a multifocal patient and you have to do it, it's possible to do it.
Dr. Mohan, thanks a lot for me. Just one question is, if you already know on ASOCT that there's a PCR, would you hold back from promising a multifocal or a toric and come clear and just do a 3-piece?
Yeah, I think if it's a first eye, then I will not tell them that I will be able to put a multifocal lens. Even the previous question also, if the first eye, I would not I would prefer to put an MA60 lens because these are typical dehiscence of posterior capsule, the two pillars on the posterior capsule. It's not like a posterior capsular rent. So ideally, a MA60 lens or a multi-piece lens in the sulcus with the optic capture will be the way to go. But if I know the pre-operatively there is a rent, then I would not suggest that I'll go for a multifocal lens for these patients. Yeah, I have to tell them the other options as well, the possibility of a nucleus going inside, the vitrectomy, we have a backup. I myself do it if there's a posterior the problem, the posterior this thing as well. So I think Gaurav's talk is fantastic. Even if the patient does not pay for posterior polar cataract, I do femto 100%. The reason why is that because easy, everything is there. You need to just go, don't have to rotate the nucleus, go and pick it up and come. That's all. Yeah, that makes life very, very easy. And as Gaurav beautifully showed, I think it's the way to go.
Wonderful. Thank you. Here, our last speaker, Dr. Kumar, and all of us have to be there. I'm sure it's going to be an amazing talk. On to you, Kumar. Subluxated cataract would be a very challenging talk. We look forward to hearing from you. Could you share your screen?
Yeah, I am sharing it already. You can see it.
Yeah, go on.
Yes,
Yeah, Kumar.
Yeah, so I'm not going to enlarge it now. Sorry about this. There is a glitch still at my end. I don't know what to do about it. So all networks I've tried 5G, everything, but it's not working. Anyway, I'm going to talk about subluxation and femto technology. So yes, the advantage in subluxated cases. Fragmentation can be done in subluxated area. And another advantage is fragmentation with cubes. So this is another case where you can see the subluxation. And this is one case that I want to show you where, yes, this is the femto. You can see the femto. You can see the amount of subluxation here. See the whole area that is going down, which I'm adjusting the rexis. And now this was my first case of subluxation. So I make a very, very small rexis by mistake. So you can see that I made a rexis here. The subluxation is inferior. Okay. So here I'm doing capsulotomy. Quite well. 9 millimeter. The subluxation is inferior, not to worry. I'm going ahead and doing my rexis and doing my fragmentation. This was a soft cataract. So just let us see how it goes. So 1.9 second.
I think Kumar's
and fragmentation plus a large area of subluxation. So you can see the small, now big advantage here is it's a soft cataract, a traumatic cataract, a 22-year-old male patient. I'm just going to lift the rexis and then I'm going to do a bimanual IA. So I'm doing a bimanual IA because it's a soft cataract. Somebody was talking about soft cataract. Here you don't need to do phaco at all. You can just do a bimanual IA and that will completely aspirate all the cortical matter completely. So here I'm going ahead and doing this. And then I'm going to go ahead. So you can see the inferior subluxation decentered, but the IOL will center in the center of the bag, irrespective of where the rexis is. So here I'm going ahead and putting an endocapsular ring in the bag. Once the endocapsular ring goes into the bag, it just goes ahead. And then I put the lens in the same area of subluxation. So that a haptic gives additional support. And thing is the subluxation cases, rexis comes out beautiful, and then you can just make a little nick, extend it, and go ahead and do it. I'll show one more case because it's only for 5 minutes. Here you can see again the area of subluxation is here. I'm going.
No, not able to hear you.
Going ahead and doing femto. Now I'm little more cases in between, but here you can see that inferiorly there is some amount of subluxation. So here I'm going ahead and doing fragmentation. You can see the subluxation on the femto. Now you can move the rexis in any direction. And now I'm doing a 4. .9 millimeter rexis and moving the rexis away from see clinical. So we're going ahead and doing fragmentation and then doing the case clinically. So let's see how it is. So here I'm doing again, you can see it's topical anesthesia. I'm seeing whether there is any donesis. The subluxation was only from here to here. So 3 o'clock position, you got a nice rexis and you got fragmentation even in the area of the subluxation. So here I'm going ahead and putting the 2 capsular hooks. And once you will notice that once I put the capsular hooks, that gives my support. So here I'm just going to go ahead, pinch the rexis out. Once the rexis is out, going ahead and putting the capsular hooks, which supports the fornix. So we are just going to go ahead and put the capsular hooks and make sure that we are supported in the fornix of the lens. Going ahead and doing that. Okay, going ahead and doing this. So once I have done that, I'm going again doing phacoemulsification. Now, fragmentation in the area of subluxation is not possible in any other method except Flacs. So that's one big advantage here. I'm just going ahead doing rotation very, very easily. because the subluxated area is very small, and that's the reason why it's quite easy to manage this. Once the phaco emulsification is done, we are going ahead and doing this part. Once this is done, we are going ahead and then see, you can see that once the rhexis, the capsular hook came off, not to worry, you can see the amount of subluxation from here to here. And I'm just putting this. Now I go ahead and put an endocapsular ring. Once the endocapsular ring is placed, I go ahead and put the lens in the same area. So again, I put this. Now I'm putting the endocapsular ring. Once the endocapsular ring is placed, I go ahead and place it inside the bag. And that's very important, that the eyelet of the support, at that time, you may have to loosen your capsular hooks a bit, because now you got the support of the endocapsular ring. You really don't need the capsular hooks there. Just remove the capsular hooks at that stage, loosen them, they take them out of the bag, and then go ahead and put the endocapsular ring that is necessary. Now, the eyelet of the endocapsular ring may come in the area of subluxation. If that does happen, you just rotate it a bit and then take it ahead. So here, what I'm doing is, you'll notice that I'm going ahead and rotating the eyelet of the endocapsular ring and giving full support of the area of subluxation. And then I'll put the IOL in the same direction of the area of the subluxation. So once you have the eyelet, the endocapsular ring inside, all you have to do is remove the capsular hooks and then put the IOL in the same direction. So according to me, Flacs is a huge advantage in certain cases, like rightly said by Gaurav, about posterior polars, subluxated, hypermature cataracts, where you get a perfectly round rhexis, well-centered rhexis. Here you get a rhexis wherever you want. Here again, I'm putting the haptic in the area of the subluxation, and that's one big advantage. So advantages of femto is incisions. CCC is where you want, what size you want, whatever you want. Hydro is made very easily because you have a pneumatic dissection, and fragmentation in the area of subluxation is also there. And this results in reduction of phaco energy. Thank you very much. Sorry about the glitch. I'll stop sharing.
Thanks a lot, Kumar. A question to you and Dr. Ramamurthy. Do you all feel that placing capsule hooks and iris hooks are not as safe with the femtorhexis as compared to a manual, or these are all just conjunctures which have no backing of literature?
So I'm actually going to make a very interesting video this year, which is going to remove this myth. According to me, if you have a complete free-floating rhexis on a femto, it is as strong as a manual rhexis. But if you have an incomplete rhexis on the femto, it is a weak rhexis. And that can give way and that can tear off. So it's not weak because it is weak because it is incomplete. Otherwise, it's equally strong. This is my contention.
Dr. Ramamurthy, Dr. Naren, Dr. Shail, any one word on it if you differ?
Yeah, I tend to agree with Kumar. I mean, any incomplete rhexis is a weak rhexis. And initially when femto came up, because of the direct contact on the corneal surface and distortion of the posterior desmids, there used to be aberrant pulses on the capsular rhexis, skip areas, posterior stem kind of rhexis, which was proven to be somewhat weaker than the manually created rhexis. Now that we have either a contact lens or a fluid and this distortion of the posterior corneal surface is not there, the rhexis that is created is as good as a rhexis which is manually done. Of course, there are some studies which show that it is double the strength of a manual rhexis. I am not completely convinced about that, but there is enough evidence to show that it's as strong as a manual rhexis. At least whatever maneuvers we are required to do, whether it's implanting an intraocular lens or using an endocapsular ring or a capsular hook, the rhexis very well withstands that.
Yeah, agree. Anything, Naren? Yes.
I completely second that. I've operated subluxated lenses with these femtocataracts and used capsular hooks, CTRs. Absolutely, it behaves just the normal. And also, it's extremely important. If the rhexis is complete, I don't think so. It should. It's never extended. At least in my hands, I've never seen it extending at all.
Only thing that I would caution is that if on the OCT, if you see an actual significant tilt of the lens, those are not the ideal cases which I would suggest to consider for Flacs to do the Rexes also. So I think Flacs is a great adjunct in subluxated cataracts, but only for a mild sort of subluxation, not for a moderate to severe subluxation.
Because of the tilt, the dog would not be centered, and then your capsulotomy may not be complete, and those challenges are there besides other issues. Thank you very much. There was so much of information which we gathered in this very interesting webinar, and I really owe my thanks, rather ARC and my whole team owe our thanks to all the expert panel. I know even Mohan stayed right till the end, had a wedding to go to, and I see Dr. Ramuti there sitting and helping out. And each of you speakers and your massive contributions. Of course, there were so many talks and there had to be some basic discussion, so we really run out of time, but thank you very much, one and all of you. Thanks so much, Dr. Satyajit. Just seeing you there was like a huge energy for me. Thank you so much. Of course, I have to thank my ARC team all the time for their being there for me. And we need to thank the AIOS team headed by Kripal. We need to thank Sai and Manjula from Numerotech for all the support which they give. Thank you so much, Mr. Sunil, for being there and trying to help me all through those difficult moments in each of these different webinars. And thanks a lot to Entod for their constant support and sponsorship. And finally, and most importantly, thank you, delegates. Thank you so much. I know quite a few of you have watched this, and I know we have tried our best with the network issues and other challenges to give you all what we could in the form of a little more learning on this Wednesday evening. Thank you all. Thank you so much. Thank you.
Thank you, ma'am, and special thanks to Ramamurthy sir for being with us throughout the evening. Thank you so much, sir.
Thank you to Dr. Sandeep Shell for being right till then.
Thank you, Dr. Naren. Thank you, Dr. Shell. Thank you, Dr. Sandeep.
Thank you. Thanks, Debashish. Thanks so much.
Thank you, Sunil ji.